Jermaine Timlin, official room monitor. But I'm really here to introduce our guest speakers. So a couple of housekeeping notes. First off, can everybody silence their cell phones? Secondly, the washrooms are right outside the door next to the elevator, men's and women's. There's also a water cooler there, so if you get a coughing fit, you can go get a glass of water out there. Circulating is the sign-in sheet. You are going to be required to sign in and sign out today at the session. So some of you signed in earlier, but the sign-in sheet is circulating around. So again, welcome. Our program this morning is 2 approaches to management of the chronic lumbar hip pain, the movement systems impairment, and functional manual therapy, being presented by April Oury and Robert LeBeau. April graduated from Boston University's Sargent College of Allied Health Professions in 1997 and moved back to the Chicagoland area to start her career in acute and inpatient rehab. She then took on the challenge of working with orthopedic cases at a national rehabilitation company and became the site manager at her facility. A few years later, in 2004, she decided to open Body Gears after working for a physician group. This allowed her to focus and achieve the highest standards of excellent patient results through one-on-one care. Throughout her career, Ms. Oury has sought to increase her manual therapy skills. She obtained her integrated orthopedic certification in 2000 through the University of St. Augustine and the Institute of Physical Art. In 2003, she went on to complete her functional manual therapy certification from the Institute of Physical Art. Then in 2009, after a year in Steamboat Springs, Colorado, and you're coming to our cloudy Midwest, she obtained her fellow status in the American Academy of Orthopedic Manual Physical Therapy. Our second speaker, Bob LeBeau, recently achieved the status of Fellow of the American Academy of Orthopedic Manual Physical Therapist from the University of Illinois at Chicago. He graduated with honors from UIC with a bachelor's in physical therapy, and in 2004 he was awarded the distinction of Board Certified Orthopedic Clinical Specialist by the American Board of Physical Therapy Specialists. Bob began studying with the Institute of Physical Art in 1999 and achieved the status of a certified functional manual therapist in 2008. In 2009, he began teaching with the Institute of Physical Art in the functional mobilization and back education courses, as well as training core first strategy classes. Bob is also an APTA certified resident instructor and is currently pursuing a Doctorate of Science degree in orthopedic physical therapy from Texas Tech University. Let's welcome Bob and April.
Good morning. My goodness, to hear all that stuff makes me a little cringe, but it is what it is. Thank you guys for coming out this morning. I hope it will be a great course to maybe learn some new techniques, new thoughts, new theories. We're hoping to show you guys how we clinically reason through cases rather than just lecture. So this course is both a lecture, just to give you some background information on the topics, some definitions, some thoughts and theories, some things to put into your brain before we go on and actually do some demonstrations. So hopefully it'll be an exciting little class. So the first half will be lectures. I'm going to go through my little portion and April for hers. And then we'll actually go through an evaluation and how to go forward and treat some patients using 2 different approaches. Now the discussion of 2 different topics, motor control and manual therapy. In our realm, we like to try to use both of them interchangeably, but out there in the public, you're either an exercise person or a manual person. You don't marry the two. You treat them by getting them moving, or you treat them by getting them joint moving. So is it moving too much, or is it not moving enough? So there's room for 2 of them, but I want to appreciate the controversy of the 2. And if some of you guys are big into movement therapy and motor control, you can appreciate how manual therapy might assist them. If you're big into manual therapy, you can appreciate how movement system impairment or motor control activity might be beneficial to really help your patients achieve their goals and really be good at what you're doing. But anyhow, here we are. Course objectives: describe and define a motor control movement-based therapy program. Describe and define a manual therapy system. And there's a lot of different karate dojos out there. We're particularly representing the Institute of Physical Art out of Colorado. But again, basically manual therapy and motor control. Those are two basic topics that we got going on. And there's different karate dojos and manual or movement therapy as well. We're just representing the one down in St. Louis while we do this one. Describe and define clinical patterns, presentations of lumbopelvic and hip pain, and how the diagnosis can be addressed using both manual therapy or motor control, or manual therapy and motor control. Demonstrate two approaches, the clinical reasoning behind it. I always find it fun when I go to conferences to watch the presenters, you know, what are they thinking about, what's going on. It's fine to sit there and get information and shove it into your brain, but it's more interesting to see why are they coming up with that? What's going on? How's that going to change my practice about how things are set up? Two approaches that we're talking about today, one being manual therapy and the other being motor control. Again, I already went over the controversy that exists between the two camps. One's more passive, one's more active. Does it hurt because it doesn't move? Does it hurt because it moves too much? Is one better than the other? Maybe in certain circumstances one might be better than the other. Some people say I could treat everything with manual therapy, other people think I could treat everything with motor control. We're going to see if that's possible or if there's a balance and a blend that can really help things along. Should they be combined or kept separate? Two approaches, manual therapy on one side, motor control on the other. If you work in a practice, a clinical practice, that there's a manual therapy guru and a motor control guru, this is probably how they meet up in the hallway. I'm better than you. So one of the big things at IPTA conference, APTA conference, whatever conference I'm at, we have to stop fighting each other and stop fighting everyone else. So these two people should turn and fight everyone else or fight the problem, the dysfunction that the patients have. And then as a profession, physical therapy will move forward. Again, stop fighting each other, maybe combine our practices. This dojo talk to that dojo, we get a really good balanced approach, really to be successful. So today I'm going to talk about motor control a little bit, and April will talk more about the manual therapy approach, and then we'll blend it at the end. Following are based on the works of Dr. Starman down in St. Louis. I had the opportunity to study with her in the fall and just be introduced to what she's got going on. I've always been leery of her approach because it confused me. All these definitions and words and wobble wobble and smasho squeezo and her funny humor. It's like, what is going on with that lady? So we invited her up to UIC a few years ago, and she gave a talk on the manual therapy forum, and it was kind of funny. It was like, how can we have this lady come up to manual therapy forum? This is our dojo. Why are we letting this lady in? But there's some topics that we could do better at as manual therapists, or as motor control therapists could do better at if you blend the two up. But anyhow, we're going to talk about some of the work that she has. And again, I'm not professing to be an expert. This is just my interpretation. So if you guys are big MSI gurus, you can kind of beat on me a little bit, or you can help me out a little bit if it doesn't make too much sense. But here we go. The body, one of the basic premises is the body takes the path of least resistance. If you're looking at a patient who has pain with flexing, and they'll have a little bit of interesting rotation in there, you can see that they're probably not moving through a segment. From a motor control segment, motor control theory, we look at why are their muscles not letting them go on the right path. From a manual therapy approach, we're going to look at why is that joint not moving. Again, two different ways to solve a problem. Some patients might benefit from one approach or the other. Some patients might benefit from both. So the topic is that it hurts where it moves. There's too much motion, as she calls wobble wobble. Too much motion at a certain segment. L5S1, L4, L5, up in the cervical spine, at certain parts of the hip. There's too much motion going on. So let's see if we could rein in that movement, get a little bit better control, move more efficiently by using movement science approach. Accessory motions and hypermobilities is a acute cause for tissue degeneration and injury. So too much motion at a segment causes injury. Not enough motion at a segment doesn't. So that's the big difference between manual therapy approach and movement science approach. Is that in one camp is more hypomobility driven, stiffness driven, and one's more hypermobility or too loose. One's too loose, one's too stiff. Movement dysfunction is a progressive condition that leads to degeneration and tissue changes. everything tends to lead to arthritis. It's just the breakdown of tissue. Everything breaks down eventually. And as I age in my practice as a physical therapist for 22 years, I'm starting to see that a little bit more acutely. I have to make sure that I'm not breaking down, I'm not moving too much where I shouldn't be, and I move enough where I should. So this is personally an important thing for me. Basic concepts. Again, this beginning of this lecture is to just fill you guys with some basic concepts, some definitions, some thoughts, so that we can actually see it in action a little bit later on this morning. Movement that causes pain is not being performed correctly. So this is where precision comes in. If they're moving through an arc of motion and they're not using the right sequence or synergy, the symphony of muscles aren't working properly. The big muscles that are strong are going to take the lead. The little muscles that are weak are going to let things go. We'll talk about this a little bit more as we go on. So what do? We're going to stop the movement that causes the pain. Stop moving where it hurts. We're going to get the adjoining segments to move better. Now, this is something out of her lecture that I peeled off, and I said, oh, as a manual therapist, and again, guys, I carry a card that says I'm a manual therapist on me. So I'm definitely a card-carrying manual therapist. But as an evolving therapist, as a revitalized therapist, I'm trying to find the best way for my patients, and that includes motor control movement. What does that sound like? Moving adjoining segments to get things to move better. That sounds like you should go and manip it, or move it, or do something to it, soft tissue treat it, get it moving. But from a movement science point of view, we want to make sure that the adjoining segments are doing what they're supposed to do, so that the segment that's too mobile doesn't get overused, deteriorate, break down, cause trouble. So basically, keep the painful segments stable. Alright, so any of you guys who are reading the recent JOSPT, I don't even know if this one's come out or not, or if it's EPUB ahead of print, but they're talking about bracing. You know, there's a lot of debate about bracing. Holding your stomach in when you jump, if you're holding on to something in the ceiling and you jump down, if you hold a brace contraction, and again, I don't know the reference, but it just came out, you're going to have increased ground reaction forces from the plate if you look at biomechanical analysis. So if you brace, you're going to increase the load, the demand. So bracing is a part of training someone to be more stable, but it's not the end, it's more the beginning. So if we're teaching our patients to brace, 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 every time you brace, you sneeze, you brace, you lift something up, you brace, if you're looking up at the stars, you brace, patients are going to be compressing the crap out of their tissues, sorry, just for. And that compression is not necessarily a good thing either. So appropriate firing and appropriate muscle contraction is really what we're looking at. This is a little different. Anyone have any children who play the violin? So they start off squeaky as all get up, right? And as they get better and they get into high school and maybe even beyond, they sound better. Why? Because they're not pushing so hard on one string. So back to what we do as physical therapists. If we're only pushing on one string in our muscle, if we're just contracting the heck out of the rectus abdominis, or we're trying to contract the TA or the multifidus or pelvic floor, we're not appreciating the fact that you have to have delicate motion throughout the whole system. And that whole system will allow us to take force the way we should and shear the force rather than just beating on the tissue between the muscle and the joint. Oh, that's too long. Alright, here we go. So accessory joint hypermobility. From a motor control point, we're really going to address hypermobility. Manual therapy, perhaps more hypomobility. What's too stiff, one's not stiff enough. So I'm going to use the word stiffness a lot in my presentation. Stiffness in one camp is a bad thing. Stiffness in another camp is a good thing. Those two stiffnesses are not the same thing. We're not talking about the same thing. We're talking about stiffness in a muscular system that takes shock, absorbs motion, it absorbs energy so you don't deteriorate your spine. The lumbar spine is built, and we're going to focus more on lumbar spine, a little bit of hip, because this is more lumbo-pelvic, hip, kind of talk on how they all kind of roll together. There's interdependence between the two systems, or they're dependent on each other. The lumbar spine is really meant to flex and extend. If we look at the anatomy, the facets orient themselves very, very upright, very in the sagittal plane. It's not meant to rotate. So and how much motion at each segment, 3, 4, maybe 5 degrees of flexion and extension. L1 through 4 rotates about 1 to 2 degrees. I don't know about you, I've been working on being a great astute manual therapist, my hands are pretty good. I can't feel 1 or 2 degrees. I can feel if it's painful, the patients can. I feel if it doesn't seem to move as well on one side or the other. But 1 or 2 degrees is very little. It's not supposed to rotate too much. It's this compression of the tissue between the joints that you're really getting that little bit of rotation. L5S1 rotates a little bit more, probably about 3 degrees. Punjabi and White's classic studies, before some of you guys were even born. I was, but some of you guys weren't around for that. Basic premises what we're trying to lay down is rotation destroys the soft tissue in the joints about the spine, about the lumbar spine. Cervical spine is made to rotate, thoracic spine is made to rotate, lumbar spine not so much. So what we're looking for is length, strength, and relative stiffness. I'm going to try to define something that really makes me interested in the Sermon Approach or MSI camp, is the thought of 2 springs. If any of you guys have ever been to any of her lectures, she always pulls out these 2 springs. She got these great long springs. I don't know where she got them. This is the best I could do, but it's a small lecture course, will be good to go. Different muscles pull on motion segments at different length tension relationships. April, help me out here for a second. So a little interaction here. Go ahead and hook your finger here. So this is a motion segment. So let's call this the hip. So this guy on top, there's 2 springs. You guys could appreciate the one on the left goes more than the one on the right. So the one on the right is stiffer, has more relative stiffness than the one on the left. So if this is the glute med and maybe the deep lateral rotators of the hip, and this is the tensor fasciae lata, the mean and nasty TFL, just appreciate, and if you turn it like this way. Oh, there you go. So if we are asking the muscle to do its thing, go ahead and pull. So now you can appreciate that she's pulling toward the top spring. So what happens is as we move throughout our day, and this is a very simplified thought, but just keep this in your head there. As we move throughout the day, and April's not doing too much of a, she's going the way she's supposed to go here. Thank you. You get the idea. If a muscle is stiffer, and again, good stiffness, not bad stiff. If the muscle is stiffer, the joint's going to go toward that. The motion segment is going to, the instantaneous center of rotation is going to bias the stiffer muscle and go away from the longer muscle, or the more elastic muscle, the less stiff muscle. Different muscles pull on motions, I already said that. So, is a muscle group, and we have to look at the symphony, the horns, the violas, the violins, all those guys. We look at the whole system here when we're looking at evaluating someone's patient for pain and dysfunction. Are the muscles too long? They're too short. They're too stiff, or they're not stiff enough. Now, one thing that viscerally in my stomach, I say, oh, if it's too long, you gotta strengthen it. Good. If it's too short, we gotta stretch it. Well, I don't know about that. Let's hold that thought for a minute. That's a basic premises that I had from my Stone Ages, when dinosaurs walked up and down Taylor Street when I was in PT school, right? So, wait a minute on stretching, because there's a lot of controversy on stretching. Should we stretch before exercises, or should we not? Does that help enhance it? Does it not? I think basically they're saying don't stretch before sports, it reduces performance. And stretching passively may not be a good thing. I can get you references if you want, but right now, that's just what I'm going to hang my hat on. So we're thinking about, is it too stiff? What does it mean to be too stiff? Again, not joints, but muscles. Think about a big bodybuilder, not myself, because I don't spend enough time in the health club. Big muscles here. If you take that muscle, and we've all done this, patients who have like big muscles, big quads. My goodness, I'm zipped on. I apologize. Big quads. Write that up.
Swearing, zipper open.
Let's digress for a second. So big muscle guys, right? So you have a muscle that you pull on it. It's not dysfunctional, they don't have pain, but as you pull on it quickly, you're going to have a little bit of resistance. It's going to slow you down. There's this passive stiffness that we're going to look into. So just keep that in mind as we move on to the program. Not my zipper. Do muscles that are too long fail to protect the spine? There's another premise that I've got going on. Are the multifidus are they too long? are the oblique muscles too long? Are they just not ready to go? So if a muscle's too long, the length tension relationship's not there. Are they going to have enough functionality to pull itself back in line? Or are they going to not have that crosslink, that muscle biology crosslink to hold everything relatively stiff? And when I say relatively stiff, I'm talking about protection, not like I can't move, I can't get out of bed, I'm too stiff. Cars or something like that. Muscles too short, stress and motion segment. So again, if looking at the TFL with the springs there, if that muscle is too stiff, I'm talking about getting muscle stiff, that's great, but if one is too stiff related to the other one, this is all in relationship, you're going to have a joint that's moving toward it. We already discussed this. So that's just something that's just keep on your front burner for a few moments as we go through this morning's lecture. What is relative stiffness? So here's a concept. Relative stiffness. So leave it to Shirley Sharman to put another word in front of things and make us all confused. Again, relative stiffness is one muscle that is more relative, that has relative stiffness. It doesn't elongate really easy. It's there, it's protecting, it's on, it's ready to go. It will take the load. Just think about if someone comes and wants to punch you in the gut. If you have relative stiffness in your abdominal wall, it's going to hurt a lot less than if you don't have relative stiffness. An active muscle contraction, think about bracing. If we're going to brace something, we're going to stiffen the segment up. Fantastic. It's there to protect the spine, it's there to improve posture, alignment, it puts you over your axis, active readiness. That is something that we can't achieve all the time. If we fatigue, if we get tired, if we're looking the other way, if we're always having to think about bracing, we're going to compress that spine, we're going to cause trouble. So bracing has a purpose in the initial stages when muscle movement isn't automatic. It's something that's more of a cognitive. All right, I gotta go over here, I gotta tighten this muscle up. But what we're looking for is really the passive stiffness. So passive stiffness improves the length tension relationship, meaning as the muscle gets pulled, that passive stiffness resists it. So let's think about the rectus abdominis and the terminal oblique. If I'm sitting here at what we call an extension syndrome, if these muscles are very, very loose, I'll tend to go toward the stiff spring of the spinal erectors. And then you're going to have a lot of compression and deterioration, degeneration, because these muscles aren't going. So in classic theory, let's just tighten these muscles up. Well, great. But what we really need to do is power them up, train them so aggressively that they start building sarcomeres in parallel, not in series, but in parallel to stiffen that up. So my body says, oh, I don't want to go this way. I have a tight spring that's pulling me forward and in better alignment. Larger the muscle, the stiffer the muscle. I'll give you an example of a bodybuilder. Here's a student right now with the beefiest muscle. So I say, all right, look at Kyle. See this guy? Look at these muscles. That's the idea that we've got in mind. We should take a picture. So lastly on this slide is what the big dog here, the protein, the part of the body that really does this is called titin. Titin it acts as a spring at the end of the myosin and actin fibers. So here, let's see. Oh, perfect. It works great. So see these like little springy guys here on the end? That's titin. The more we build up our muscle, the more we ask that to be the muscle that's on and going and doing the job, the more these guys get laid down. For each, I read in the text, for each myosin filament there, you have up to 6 titin. So the more sarcomeres you build, the more strength training you propose for a muscle, the more of this titin. So why is titin an interesting thing? Because that's a spring. That's a little tightness spring. So you have more relative stiffness based on these large proteins that are in the muscle. So if we have more of this protein, we're going to have more resistance to passive elongation, more relative stiffness. So that's enough confusing talk. Why is it so important is the muscle will be more ready to protect. The length-tension relationship will be more advantageous, more beneficial. And your spine is going to move in the way it's supposed to, not in the way that it wants to. The abdominal wall has a lot of different muscles. You say, Bob, you're going to talk to us about the external oblique, how important it is. How about the internal oblique? For goodness sakes, how about the TA? Everyone loves the TA. The people in in Australia, they love TA. I'm not a real big TA fan, multiple. I mean, I like the whole symphony. You know, it's not just saying I like the horns, I like the bassoons, whatever. You have to appreciate everything works together. And I think in the research it has been way too much of one or two or three things. The fact that everything works together. Now in the MSI world, big on the external obliques, and the rationale is because the external obliques are best designed to stabilize the pelvis. If the pelvis isn't moving too much, the spine doesn't rotate too much. And if these muscles, especially the external oblique, the multifidus, the TA, the psoas, the muscles that are supposed to, strike the psoas from the discussion, but the muscles that are supposed to actually stabilize the pelvis are working, then the hip muscles or the back muscles are supposed to move. So there's the stabilizers and the movers. The movers can move. What happens a lot in dysfunction of this area is the movers, the stabilizers are out to lunch, they're on vacation, they haven't checked in yet. Prime movers are the ones that are stabilizing it. How many people treat hip and back pain patients in their clinic? A handful. Alright, so how many patients have significant inner groin irritation? You push on the trigger points, they jump off the table. They have length tension relationship issues, they're always fired up. So me, I'd go ahead and put a dry needle in. I don't know if we can still do that in this kind of state or not, but anyways, don't tell anyone that I'm doing that. But you soft tissue treat it, you stretch it, you mobilize the joint. But what we have to appreciate is the prime movers are doing the stability. So if the stabilizers aren't working, the prime movers have to stabilize because the back has to be stable for movement. Stretching, stability and motor control. In MSI, they talk about stretching does not correct a movement. So if you have a real stiff segment, do we stretch it? The answer is not really. You do a little active stretching, but really we correct the motion, correct the movement, and we'll stretch the muscle. So if we use the proper movement strategy, the muscle will have to elongate because the body will move that. Again, the body goes to the path of least resistance. So what will happen is the body will use the tight spot. It'll go away from that and it'll start breaking down the joint. I've said that a few times. I'm gonna probably say it again a couple of times, so I apologize if I'm redundant. But this is really the concept that we're looking at. Does movement occur at the right place? If you're looking at someone moving, are they flexing where they're supposed to flex, or are they extending where they're supposed to flex? Are they rotating where they're not supposed to? Are they not rotating where they are? Does movement occur in the back, or is it supposed to occur in the hips? So many times I see patients, especially my age and above males, stiff as all get out. Younger women, not stiff enough. So the body's going to break down somewhere in between. Back to our discussion a few moments ago, are the movers acting as stabilizers? That's one of the biggest things that I treat a lot of patients who have hip pain and back pain. The stabilizers aren't working, prime movers are moving, they're acting as stabilizers, they just do a bad job. We talk about local and global muscles a lot in back pain and rehabilitation. Multifidus does a better job stabilizing, and erector spine does a better job moving. So I think if we have the stabilizers not working and the movers trying to stabilize, all hell breaks loose. In summary, patients with lower back pain generally move earlier at the spine than patients who don't. Meaning, if you ask them to move their leg or rotate their hip, they're going to rotate at their back well before they rotate if they don't have pain. Hip lateral rotation produces early lumbar pelvic, I should have spelled that out, I'm sorry, motion in lower back pain patients. So if you have the patient sitting, and if they generally have no back pain or no history of back pain or significant back pain, as they rotate their hip, they don't rotate at their spine. If they rotate their hip and they generally have this dysfunction, they're going to twist and torque. And the twisting and torquing is really why they are in your clinic in the first place. If they're in prone and they bend their knee up, I mean, if you lay on your bed and you try to transfer, or you're moving around with normal functional activities, if you flex your knee in prone and in supine, early lower back motion, lumbopelvic motion occurs again in the cohort with lower back pain than patients who don't have it. It's kind of funny, how do they find patients who never had back pain? This is more like patients who have active back pain versus than patients who haven't had it for a very long time. It must be young students or something. Training, now here's the big deal, training improves stability and function. So if you train them with motor control activities, it improves stability, improves strength, it improves their pain. And that's why they're there. They want to get stronger, they want to function better, they want to have less pain. Patients with low back pain generally have decreased hip range of motion. It's another study by Van Dillen. So they start stiffening up elsewhere. They have too much motion somewhere, they start breaking down elsewhere, start stiffening up. And they have lack of motor function, meaning they don't have the strength. So talking about the hip, I'm going to talk very briefly, this is a very important topic for me, hip morphology, cam lesions, pincer lesions, acetabular versions. This is, for the purpose of this class, I just want to talk about architecture. The patient comes to you, has architectural deficits, can we change them with motor control and manual therapy? A little bit, but what we're trying to do is change their movement patterns so they don't beat themselves up further. That's a little picture from 2004. The one on the top in the A is a normal hip. You have a little bit of overgrowth there for a cam lesion. And then you have a pincer lesion on the top, and you have a combination. And this is what is happening to all these patients who need the labral repairs and the FAI osteochondroplasties. But we know how now. We know what is going on, but we don't really know why. So surgeons are getting better and better treating this. We're probably doing a better job rehabbing it, but realistically, why are people breaking down at the hip? Well, I'm going to go out on a limb here and say probably because they have crappy motor control. They have an inability for their muscles to pull themselves in the right spot, and they start breaking down elsewhere. They're not supposed to rotate at the spine, so that they have too much rotation at the spine. The hip goes forward, pinches on the tissue. You start to have bony overgrowth and bony changes, architectural changes. And you have dysfunction that leads to a very serious condition that's hard to treat. A little bit on hip musculature. Hips are very, very important. Not that I wanted to show you a picture of someone's bum, but gluteus maximus, minimus, medius, and deep lateral rotators are the unsung heroes of the war on back pain and hip pain. Patients generally come to my office, I check their functionality, and I realize that their butt is just for show. They're just wearing it. They're not actually using it. So what happens in the hip case, back to the hip case, is as they are stepping forward, instead of their glutes and the medial aspect of the hamstring and the adductor group working properly to pull their hip in the socket, that hip is going forward, pinching on their labrum, breaking things down. So if we're looking at getting the functionality back, we have to appreciate the symphony again. The musicians who are really holding it all together, holding that note together so that we work efficiently. Individual low back pain move different. I already said this, so I want to say it again, just so I like to add more and more slides on research to make it look smart. Patients move different than patients who do not have back pain. We know that, we see this all the time. They're kinesiophobic perhaps, they arch when they shouldn't be arching, they don't curve reverse. They ask the questions why. From a motor control standpoint, is the right muscles aren't working, the wrong muscles are working too much. Decreased performance of lateral rotation, it's seen low back pain, again I saw it before. And you guys, if you're big research readers, you'll find one author will put the same thing out in 4 different ways to get 4 different papers published. But the cool thing is it really just hits home in the importance. And the importance here is that hip musculature, back musculature, firing the right way really protects the spine. And the cool thing is it's trainable. We can get this back. Syndromes, I'm going to blast through these. We'll talk about it a little bit more in the lab portion of it. So in the MSI approach, they're big into naming, diagnosing. We have to diagnose things. So what we look at is, does it hurt when it flexes? Called a flexion syndrome. Does it hurt when it extends? It's an extension syndrome. Does it hurt when it rotates? Rotation syndrome. Does it hurt when it rotates and extends? Flexion rotation. So oftentimes you'll see any combination of these. Patients will have problems with rotation and flexion and extension. Very, very straightforward examination. And here goes for you. You guys can read these online. We have these published on the IPTA website. But looking at extension syndrome. So Patients who have extension syndrome have very, very weak abdominals. They have an increased length. This is that spring that's too mobile. And they just kind of pull it out there. Or they're trained to be this way. Gymnasts don't have really weak abdominals. They're great, but they train to be this way. What happens, I say it's great. They work, but they have too much length. They're always back here. They're too short here, and they're too long here. So abdominals have poor control and too long. Flexion syndrome, back extensors are poor and long in length. I've appreciated the fact that I probably have a little bit of this myself, because I like to do this. So my theory is my mid-back muscle is too damn long. My other muscles here are probably too short. So I've got to build sarcomere strength and functionality of these guys to get this up. Because this is not my go-to posture. I could do it all day long if I know it. Or people in my clinic say, Bob, you're sitting like a question mark again. So I got to bring myself upright. But from a motor control point of view, I might need to just stiffen up my upper back muscles. Not stiffen up my back, but stiffen up my upper back muscles. Now what else is good on this one? Stiff extensors. So they'll have stiff muscles that extend the hip as well. Rotation syndromes are generally very poor control of the muscles that help rotate the spine. The obliques, the external obliques, really not working well, and perhaps the hip rotators too, not working so well. Movement exam, I'm going to blow through this because we're going to come back to this. This will make a lot more sense if I have a patient in front of you. When we look at patients, how does these look? What do they look like? Are they flat? Are they extended? Are they rotated? Is one hip rotated to the other? We're looking for kind of big things. Or if we look for very minute things, we probably aren't going to get it. If we look for big things, probably make a big change if we change it. One for pronator supinator. Looking at press level, tilting the pelvis. Then when you look at how they move, that's the whole thing about a movement exam. When they move, do they bend forward? Do they reverse curve properly? Is their spine moving into all sorts of flexion and their hips aren't? Or are their hips flexing and their back is? What's it look like with side bending? Symmetry one side to the other. Are they bending where they're supposed to or they're not? Are they all in the lumbar spine hinging like a hinge on a door? Or do they share that motion with the other vertebral segment? See the leg stance. How does the hip work? Do they drop? Do they flatten? Yeah, we'll be back to this very soon during the demonstration. We'll go through this a little bit more succinctly here. Spinal alignment and sitting. What's their strength of their hips look like? What is their strength of their hip flexors, their hip rotators? What's the length of their hamstring? Do they have appropriate length or are they a little too stiff? Supine. Again, how those muscles work. What happens when you flex the leg up actively? What happens when you have it passively? Do they have relative stiffness in one spot? Do they have active control of their pelvis, or do they flop around? Are they wobbling around? Sidelines. What's their glute med doing? Are they firing up? Are they getting strong contractions? Do they have stability there, or are they wiggling around in their spine? So I hated the clam exercise. Hated it. I would, during my fellowship, I would holler at anyone who did clams. I didn't know why I hated them, but I just hated them. You go into any PT clinic, they're all doing clams. So I was talking to Shirley Charman when she's at UIC. I said, I hate this exercise. I just can't handle it. She goes, let me see how you do it. So I had someone do a clam. She goes, that's a bad clam. Bad clam. You guys ever eaten clams and you eat a bad clam and spit it right out? Well, I'm going to ask you guys to spit out bad clams and look over to the good tasting clams. That's weird at this time of the morning. But what is a good clam? A good clam is having hip abduction and lateral rotation at the hip socket with a good stable pelvis. So if their obliques are firing up, and if they could sit laying on a sideline on a table and have stability where the spine is neutral, not necessarily with any pillow or support unless it's in an acute state, and they can rotate only at that segment, not rotate at the spine, that's a good clam, and that's important for motor control and function. But we send our patients home doing these awful clams. Oh, my back is hurting after I do exercise. Why? I didn't teach them to do it right. I actually just stopped doing it, but now I'm back. I like good clams. Prone knee flexion. If they bend up, is it the rectus femoris? Is it too tight? Is it too stiff? Is it long enough? Or do they have poor abdominal function? Are they just wiggling around? Are they twisting? Where is that degeneration going on? What is the Craig test? Craig's test is important because we want to look at the architecture of the hip. What's going on at the hip? Does it antevert? Does it retrovert? Is there something we can fix, or is there something we have to do some activity modifications so we don't be glute over? What's the glute max doing? Is it working? What's the strength? Is the hamstring, glute, and core muscles firing at an appropriate synergy? Quadruped. How do they move in these different patterns? Are they doing it right? Are they twisting? Are they torsioning? What's the role of biomechanics? Chris Powers, California, is big on patellofemoral. What is the patellofemoral slide doing in my presentation? Well, if you think about what's going on in the knee, we have to appreciate what's going on in the hip. Because what's happening is the obliques aren't working properly in the abdominal wall. Your hip rotators are going inward, your adducting is really sloppy, it hurts the knee. So if we're spending all day long taping the knee, doing lots of straight leg raises, doing quad sets, doing all sorts of running and jumping drills, and we don't look at the biomechanics, and this is some fancy stuff. If you have an iPhone with a, what do they call it, not MoverSense, huddle tightening, new thing on an iPhone, just have them run and jump. Have them start and stop. See what's going on in their hips. And then you tell them to stop it. Do it the right way. And all of a sudden they start building up strength and relative stiffness of the right muscles, and then they're good, and they're happy. They stop being your patient for that episode, and what they bring in their other patients, like, this guy's brilliant, use the phone to see how well I do. What are the treatment principles? A failed test becomes the treatment. So big in MSI world is not doing 122 exercises, but doing 2 or 3 exercises 122 times. Get what you train. Be very specific of what you train. Don't let them do bad clamps. Don't let them do sloppy technique. Train to improve the function of the muscles with precise motion. Same thing I just said. Improve, remember that tighten slide. Improve that tighten. Build up those sarcomeres. Get some stiffness in the right muscles. Get some length in the other muscles. So how do we lengthen the other muscles? Stiffen up the ones that are too loose. And actively move in an appropriate pattern so the body starts moving efficiently. And very important, improve the muscles to act as the go-to muscles. So if your rectus abdominis is the go-to muscle, you're always going to flex. If your obliques are the go-to muscles, then you'll have a nice little stability through the pelvis. Kind of in conclusion, I've been talking a long time. Thank you guys for not falling asleep yet. Muscle dysfunction factors. Hip extensors gives you a lumbar, so if you have weak hip extensors or inefficient hip extensors, you can have a lumbar flexion syndrome. That means that tush muscle is, you're just wearing that for show. They're not working to protect the back. You have flexion syndrome. Weak hip flexors or inefficient hip flexors, you're going to have more of a lumbar extension syndrome. Now that's the patient who's really arched back. They're moving very inefficiently. Your dancer, your ballet person, your person has stenosis. They're just using the muscles the wrong way. They're always compressing posteriorly. Hip rotator, weak hip rotators and abductors, you're going to have that rotation syndrome. So you say, Bob, what if you have both? Or all three? All three is really rough. You generally have 1 or 2, and those 2 would be a rotation and a flexion extension. Structurally, anteversion and retroversion, what happens? Your spine is going to have to move around that architecture. So if you do an examination and you find that you have some architectural issues, instead of getting all excited and sending you to a surgeon to get it cut off, say, well, let's move your hip out a little bit. Let's see if we can modify your activity a little bit, change the way you do your motion control. Cam and pincer, we just talked about that. But if you have cam and pincer, you're generally going to have a lumbar dysfunction. And it's generally going to be a flexion dysfunction. Those patients come in after hip surgeries, about week 6, let's start treating your back. How do you know my back hurts? Like, guys, you've been breaking down for 1.5 years, your back's going to hurt for 2 years. And then hip and lumbar degenerative joint disease, you can see in both rotation and lumbar extensions. And then off to you, right?
Yes. I need to move my skeleton over, so if you want to take a quick stretch break. Hopefully your time is actually fully up. 2-second stretch break and move on to FMT. Thank you, Jermaine.
All right, if
you have stragglers, just show them the PowerPoint that you have already pulled up for yourself. All right, so my name is April Ari. Bob and I work together, and we have had so much fun together for the last couple of years because we do come at treatment from a different philosophy, but we figured out how to put it together. And so the fun part for us today is showing you one, then the other, and then eventually, you know, just like we do in the clinic, hey, Bob, I'm kind of stuck with this patient. What do you think? Well, have you talked about that yet? No, I haven't even looked at that. Hey, April, you know what? I was doing really great with this patient. Just want your eyes on this. I mean, we say that literally every single day, all day long with one another as therapists. So we wanted to bring that to you today. So my background is definitely more Institute of Physical Art, functional manual therapy background. I also teach with them and have been doing so since I think 2000. And just a fantastic organization. Founders are Greg and Vicki Johnson. They're also very good friends of mine. They're also mentors of mine, as defined by these two sitting up front yesterday at the mentor presentation. If you missed it, I strongly recommend you get the download online. It was really a great presentation. And they really fit that for me because a mentor isn't just somebody who teaches you things, but they help you out with a number of different aspects of life. And so Greg and Vicki have been very instrumental in my personal growth as well as my professional growth. So I have a great deal of respect for them. They started out in 1978, after I was born as well. And they had a very strong neuro background. So they were actually at the Kaiser Vallejo program, working with mostly neuro patients. And understanding that function, before function was a big buzzword in the insurance industry and the personal trainers now in the fitness industry and PT, that it was all about, can the patient get themselves from the toilet to their wheelchair? That was function at that point. And so what they were looking at is, how does the muscle fire? How can I get them to activate? And can this person do that themselves? And how much assistance do they need, right? And what they were getting frustrated with is, at some point, they've got the patient on the toilet. And like, okay, we've done that part. OT has helped out with what they're doing while they're there. Now we need to go to the next level of movements. Okay, we're going to transfer. And the patient didn't have some sort of X that they couldn't figure out what it was. And then they started realizing that their manual therapy background, because they also were very involved with a lot of they call them body workers at that time. We don't really call people body workers anymore, but the massage therapists, the Rolfers, anybody who's working on the repairs, more of the joint mobilization ideas, and going, okay, well, we're treating these neuro patients, but if their knee can't bend to get it underneath them as a base of support, it doesn't matter how great their muscles are, they can't get from the toilet to the wheelchair. And started then treating their neuro cases more like orthopedic cases, and started doing more manual therapy for these patients and getting pretty phenomenal results. So they ended up founding the Institute of Physical Art and marrying a lot of the manual therapy with what was called neuromuscular, not really motor control at that point, but more neuromuscular pieces together, and coming up with all the different courses that they have. I think they've got maybe 15 or so classes at the moment, I believe 6 of which you take in order to become certified as one of the functional manual therapists. So their big thing, as is everyone's, enhancing optimal movement and human function. So what are the different pillars or the operational definitions? So if we look at the IPA or a functional manual therapist, that therapist is coming to a patient with 3 different pillars. We've got mechanical, neuromuscular, and motor control. And there really is a big difference between neuromuscular and motor control, which we'll get to in a moment. So the mechanical piece of this is defined by, not is there a restriction, but can that body physically, passively get into appropriate alignment for that task? Can we'll talk about hip, can the hip sit in the acetabulum without being sheared forward, backwards, out to the side, and too much adduction for its task? Can it passively assume a position that is on axis? Neuromuscular then is the ability for the nervous system in the brain to send a message down to the muscle for it to fire. That's initiation. So there's 3 pieces of neuromuscular: initiation, strength, and endurance. So the brain says, I'd like you to fire. The muscle says, I agree. It fires. Then once it's initiated or has been turned on, does it have enough strength then for the task of toilet to wheelchair? Or does it have enough strength and endurance for, okay, maybe it turns on, and maybe it has enough strength for that first part, but does it get all the way over? Does the muscle have the ability to swing 90 degrees and do that motion? Then the motor control piece of this is the ability for the individual to automatically, and if you're writing notes, put in that little word, automatic is really important, to automatically plan and execute a movement. Because the motor control piece of this is taking a sound mechanical system with a sound neuromuscular system and then using it automatically. And the automatic piece is really key because as we start to very collegially and pleasantly banter back and forth, one of the big problems that a functional manual therapist would have with the MSI approach is that MSI is all volitional. All right, I have to think about all the time squeezing my external obliques. I have to all the time think about what muscle I'm supposed to be firing. And when you're in tasks, it's very challenging to be thinking about, okay, I'm supposed to be talking to you all and demonstrating things, but are my external obliques on? Oh, they are not. Perhaps I should remember that, right? And so, when we talk about the automaticity, that's where eventually all of us want to get our patients to, right? But that would be the differentiation then between neuromuscular and motor control. Yes?
Was I not listening or not understanding where you said that over time it becomes
Yes.
automatic?
Exactly. I was going to interrupt my colleague here, but since you did, I will jump on that bandwagon. So from MSI motor control, we're looking at a lot of volitional contraction, building up muscle so you increase stiffness. And that's a little bit different than what we're talking about here. So over time, you won't have to really think about it because you'll be in a better alignment from the proper link-tension relationship. But kind of get to it from a different point of view.
Yes, and a functional manual therapist would say, well, I'm just going to physically, mechanically place you in a new position,
Yeah.
which will create an automatic firing pattern without you thinking about you've got to squeeze it.
And I'd probably say more, train the heck out of it to put it in the right level and
Right.
get it lined up that way.
So,
Two means two now, same thing.
so mechanical movement. So, okay, without insulting you all, what do we mean by mechanical, right? And so there are different pieces of it. So mechanical structures are soft tissue. By that we mean the capsule of the joint, right? We mean the fascia, all those different areas that are loading. We've got our ligaments and tendons. Really important, our nerve and vascular tissues, right? Nerve, through its sheath, can get restricted. And so we talk a lot about nerve gliding, but again, from a functional manual therapy standpoint, why would you glide a nerve that you know is stuck and just keep cranking on it? You would have to go mechanically clear that before you then go treat, quote unquote, with movement. Vascular, also same thing. So the vascular system obviously is tubular, right? You've got a big heart that's tube, and then tubes all the way through your body, going out and coming back in, with the purpose of oxygen exchange for carbon dioxide. Those physical structures also need to be moved, because they are fascially connected to usually the nerve bundle, right? As everything goes through your vein, artery, and nerve. So as we have a mechanical tube going underneath, we'll say brachial plexus, underneath the under the clavicle, the brachial plexus with all of your arterial tissues there, all of that can be restricted as well. So think about those things too, not just, oh yeah, we're gonna move the muscle, or yeah, okay, I got the capsule. It's a lot more than that, especially when you're talking in the functional manual therapy approach. Joint restrictions, and again, one bone moving on another. So if you have two bones that are next to one another, there's a relationship where this bone can move forward, but that doesn't necessarily mean that this bone is moving backwards. That's a completely different movement, yes? Now, it's all relative, but if in space, on axis means that both of these need to be next to one another, and I've got too much motion on one side, that doesn't necessarily mean that everything now just needs to shift back, like so. Because then I'm still in a dysfunctional relationship to one another, despite my change in space physically. Make sense? So when we're talking about joint restrictions and joint mobility, we're really looking at one bone off of another within its physical space. So then the passive ability to attain an on-axis position for any joint. So if we think about, we'll just talk about the hip for right now. So the hip socket, it's this great acetabulum, and you've got the labrum to help out, make it a little bit deeper and give it a little bit of cushioning. And so if you have a hip that is off axis from a joint restriction, say, or muscle that is restricted, I wouldn't call it stiff, in the functional manual therapy world, I would call it that it's restricted because it has a knot in it. I wouldn't expect that that hip joint is able to passively get into its center position, up, down, forward, backwards, out, in, and rotation, all those different. So I would like to, from a mechanical standpoint, clear everything before I then start teaching muscles or joints how to move.
From an MSI point of view, we probably train the muscles that are weak to pull it back. So it's the same issue, the anterior glide medial rotation syndrome that's very common in hip pain, but from MSI we probably do a lot more training of the glutes or trying to lengthen the tight psoas TFL, where from a manual therapy point of view, you push it back before you start exercise.
So then, purposely using the same slides to say, hey, how would a different set of practitioners look at this? So we've got, our hip musculature, and I'm just gonna take piriformis here. Love that muscle, right? It does get a really bad rap though, right? It has neighbors, let's just remember, it has a lot of neighbors.
Raucous neighbors too,
Yes,
lazy ones.
raucous neighbors, I will say. Yes, very nice gluteus, but let's look at this part here. So if this muscle has a restriction, let's say in the muscle belly, right? And we're saying that we want to increase its ability to contract. MSI would say, well, let's get it to move. Or let's get it to move by, on the opposite side, activating a muscle, right? Which will then reciprocally inhibit the piriformis, which is a neurophysiological principle and does happen. But from a functional manual therapy standpoint, I would say in my experience, and what they would say with research, is that the actual knot that's in that tissue is not going to unknot all by itself. The crosslinks that are there, they're fibrous, they have changed the actual tissues and need to then relearn how to lay appropriately and in parallel, and that is going to be what allows us to either have a lengthen or, even more importantly, how to shorten on one another. Because we talk a lot about lengthening muscles that are too tight, but do we ever talk about how do we get that muscle to contract and be able to fold on itself or gather on itself? So if you think about just the elbow for a moment with this example. So if I can't bend my elbow, most of us would say it's either it's a weakness, right, where I can't activate my bicep, or triceps are too tight, right? Triceps are too tight and it won't lengthen. But think about this. If the bicep doesn't fold on itself and shorten itself mechanically, then it doesn't matter what the length of my tricep is. I can't get it to close. Much like if I were to take a water bottle or a softball and put it here, there's only so much I'm going to be able to move my arm, right? And so it's that idea. If I can remove the mechanical restriction, then I can get the muscle to activate, regardless of what's happening on the opposite side of the joint. All right. So, lumbosacral spine. Looking at these lovely ligaments going along here. A functional manual therapist, go ahead.
Do you guys, like we're doing a lot of talking about the musculature and the dysfunctions, speaking more along the lines of like a cause and effect relationship, do you guys ever take into account as this dysfunction may be coming from another area, as in, yes, the piriformis might be tight, causing constriction on the sciatic nerve, but do you guys ever take into consideration in either you guys' I guess experience, being that they're different, treating more outside of the location of dysfunction?
We
as
get
in the nervous
criticized by patients to say, why are you treating my tailbone? It's my shoulder. Why are you looking at my ankle? My hip is killing me. So all day, every day, yes.
Or vice versa.
And vice versa.
Ankle throw.
Yeah, ankle will,
Yeah.
right.
So absolutely, we do, and that's one of our little stretchy points with the society around us. So, we find the dysfunction elsewhere, either from a motor control or manual therapy point. We just have to go and educate whoever sending them the prescription or whatever to say, hey, we're going to treat the whole body here. We're just not going to treat one little segment or piriformis syndrome when they have weakness of the thoracic spine or ankle issues that are creating too much rotation, causing the piriformis to become irritated or stiff.
Another perfect example is a patient who's had shoulder surgery, has gone for 12 cortisone shots, they've been in 15 different physical therapy places, they love their chiropractor, but they're apparently not working anymore, so they're worried about breaking off that familial relationship. They've been acupuncture, all of those other practitioners, and then more likely than not, that's because people have zoned in on this one part of, okay, well, I guess the rotator cuff isn't firing right. Probably the rotator cuff is not firing right if someone is having that much treatment. But that doesn't necessarily mean that that's the only area that one needs to treat. One needs to then look at what's the alignment. Can the tissues get on axis? Can the humerus get on axis? Can the scapula get on axis? What about the rib cage? Each one of those ribs, more likely than not, that patient has a rib cage dysfunction and has one rib that just probably needs to externally rotate and be able to PA glide, settle into the thoracic cage better. And then the scapula now has a place to set and learn how to move. So, again, well, we don't need to go there, but makes sense? Does that answer your question? Okay.
We just use little different approaches to get them to move, but,
Yes.
but the idea is getting efficient alignment throughout the system. It affects that upper quarter, lower quarter dysfunction.
And then also looking
Great question.
from a joint perspective, if the sacrum is off axis, or let's say it doesn't nutate well, so the sacral base does not move forward, that means that this area, which is going to be the attachment here of the piriformis, is going to be inherently at a different position, right? Which of course will change the length-tension relationship, right? It just has to.
We're using the same lingo too, but it's kind of interesting that we're both talking about length tension relationship. We just talk about
Just differently.
pushing it or pulling it. So.
And so then the same thing here, just looking at all the fascia, ligamentous, if you have, so sacrotuberous, let's say you have a dysfunction here, is that going to affect the hip? Well, people would say, of course not, it's not gonna affect the hip. But how can that not affect the hip socket? Because if you look at this bone, which is the innominate, how many different connections does it have? The left innominate has how many different connections to other bones? 3, right? It's connected at pubic symphysis to the other bone, other innominate. It's connected at the hip socket, and it's connected at the SI joint. So any dysfunction that you have where this ligament is changing the orientation of this bone in space will obviously affect what's happening at the femoral, the acetabulum, right? Where the femur then accesses that bone, right? So looking at the joint mechanics then would be very important, and making sure that that innominate is in its ideal position. Okay, so underlying evidence for does manual therapy work or not, right? For those of us who would consider ourselves manual therapists, it's a pretty big deal, right? Insurance companies are saying, I don't know if it really does. Massage therapists are doing manual therapy too, so don't worry about it. We're just gonna slap manual therapy people who have lots and lots of training with people who are massage therapists, and we're just gonna cut that reimbursement by, what, 40% is what Blue Cross did at the beginning of, or end of last year? And there's such backlash that they changed that. So, that's a different issue. So related to this. Wrong talk. Okay, so McDonald et al., 2006, took 7 cases, and every single one of them had a positive response to manual therapy. Was it because they're touchy-feely people and they love to be touched? Maybe. Was it because they mechanically changed something? Possibly. Was it because the touching of them actually changed their movement patterns? Maybe. We don't really know, but we do know that manual therapy was the intervention, and they had good responses from that. Hoeksma in 2004, talking about manual therapy only versus exercise only for patients with hip OA. And we had an 81% success rate with manual therapy and 50% with exercise. Now, is it because they had therapists like Bob who are doing clams the wrong way, doing bad clams? Maybe.
Or weren't giving clams at all because they're just so awful.
That's right. Is it because they just chose the wrong exercises? That's possible. Or again, maybe they just had a bunch of touchy-feely people who really love manual therapy and connected so well with their therapist. That could have been that too. Or maybe they just had much better manual therapists than they did exercise therapists. That's all possible too. However, from all these different people, 81% success rate, that's not bad. No, I broke it. Oh, maybe we go. What did you do? Where we go down? Can you make it happen? Oh,
Broke it. So when that broke, I was
What
feeling
did you do?
sure we did it. I hit 1 and then 1 again. I hope that works for it.
1 and 1 again.
Oh, but ours turned off.
I'm gonna take it out here and see
Okay.
if it does it by itself.
Okay, so
Can't,
just
can't the Macs aren't supposed to freeze? Give us a second. Go back on.
Good job. Okay.
Reset.
Thank you. So research, Rockford did a systematic review on a number of different articles, and again found that manual therapy, which didn't just include soft tissue mobilization, it was thrust as well. So everything from just soft tissue mobilization, very, very gentle, all the way through grade 5 thrust was much more effective than just doing exercises alone. So with the IPA, being that they have 15 different courses, I only picked out a couple of different key components that were really important to demonstrate within this time frame. So we're going to be looking today at the coccyx, sacrum, innominate, and hip, and looking at how does dysfunction at one of those bones affect the low back and or hip, and we'll actually do it with a real patient. So the joint plan mechanical overview. This is what I'm actually going to check on our subject. We're going to look at the coccyx. Is it rotating well or not? So we're not looking at positional, but we're looking at actual joint movement. So does the coccyx rotate well off the sacrum? Is it in a flexed or extended position, and does it have spring to it? Side note, the sacrococcygeal junction is a synovial joint. So if you don't think it moves, check out some more research. There's a lot of research to support it. It's a synovial joint. It's gotta move, okay? So sacrum, we're gonna look at nutation and counter-nutation. And really looking at, the sacrum is so enormous, we're going to look at it very specifically within that motion, not just sagittal plane, because no one has just sagittal plane motion dysfunction or frontal planar transfer, right? It's always coupled with something else.
And from a movement versus mechanical, you're looking more force closure versus form closure. April will probably talking more about form, actually putting the joint in the socket. I'll be more concerned with force, meaning the latissimus and glutes are doing what they're supposed to do to stabilize that area. Now in MSI, she's not big on the SI joint moving too much.
As in like it doesn't move. She doesn't believe, she really doesn't believe that the SI joint moves. Okay.
But you know, you
Sure it does.
could get the form closure from forceful movements of hips.
So then the hip, we're going to look at the anterior to posterior, which is what AP is. So AP glide, as well as an inferior glide of the socket. So taking the femur like so, and because there's space here, seeing how does it glide inferiorly. Really important for patients with, we'll get to that later. So looking at Van Dillen's study about patients who have back pain, of course they have hip dysfunction, right? And that's why we want to look at that. And then for the innominate, we want to look at internal and external rotation, by which most people would say in flare and out flare, but I'm not actually going to do anything with the ASIS, because what I care about today in this presentation is not static position. I care about the relationship of bone to bone. So I'm going to look at the PSIS, and if the right innominate is in a quote-unquote out flare, which I would term, or a functional manual therapist would term, external rotation, what does the PSIS do in relationship to the sacrum? And it moves medial and anterior. Okay? So external rotation is that. Internal rotation or in flare would be just the opposite, a gapping, if you will, of the PSIS off of the sacrum. And so if you're going to turn like so, my innominate off of the sacrum would need to be able to do an internal rotation so that I can walk up. Okay? All right. And then flexion and extension. In the Institute of Physical Art, flexion is posterior rotation, like so, and extension is anterior rotation in the sagittal plane. And again, we're not looking at it overall, I'm looking at it according to the sacrum, right? Because if I'm just looking at the ASIS, there is no bone to compare it to right next to it. Okay, and remember, we're looking at one bone in comparison to another. All right. And then AP glide of the sacrum. And I do mean AP, like we're going to go through the abdomen. Okay, and I'm not going to do an indirect PA glide to L4 to see what L5 does. I'm going to do anterior to posterior and actually press on the anterior body that way. All right, and then joint arthropneumatics, how one bone moves on the other. Being that we've already talked about this, we don't have to go too much through this, but you know, how does the whole bone behave? And if really, if you're looking at, say, like L5, it's got enormous connections, right? We've got the facets on top, we've got the facets on the bottom, so that's 4. We've got the body on top, body on bottom, That's 6. It's got 6 different points of connection that we need to be looking at, and how one of those will affect the other's ability to participate in the movement segment above and movement segment below, right and left. So one joint does not work independently from the other points of contact. So again, using the same study on purpose, individuals with low back pain demonstrate different movement patterns, and those different movement patterns, kind of the chicken or the egg like you're talking about, right? Which is, do they have a bad movement pattern to begin with, and therefore their joint got worse? Or do they have a terrible joint to begin with, and therefore their muscles responded? I used to spend a lot of time thinking about that, and still sometimes it's important to me. Other times, it doesn't really matter to me, because I know that I can treat both, and if one way doesn't work, then I simply turn around and treat it the other way. So chicken or the egg, really, since you haven't followed your patients around, how do you know? You just treat what presents to you at that time. So the physical examination then, again, there's a ton of different tests that we can use as a pre or a post test or a comparable sign. I'm going to give myself these options here of functional tests, which is lumbar protective mechanism. It's a great test that Greg and Vicki Johnson came up with from runners. We can talk more about that when we do it. An elbow flexion test to see how does my upper body take weight through into my feet, because this is something that we do all day long. It's a very functional test to see how does my body respond. Active range of motion testing, we're going to look at hip, seated and standing. Lumbar assessment, same thing, range of motion. And then looking at manual muscle tests and supine and seated. So basically, from a functional manual therapy standpoint, I want to get my joint restrictions moving, and I made up this one, so I can unobstructively create movement. There was no spell correct on it. They gave me some words. I'm like, no, that's not what I want. Unobstructed creation of movement, right? So the biggest thing with the Institute of Physical Art is I want to go in the direction of maximum resistance. Yes, the body follows the path of least resistance, so if I'm going to affect change, I've got to get it off of that least resistance and into where it doesn't want to go, right? So that's where I'm going to go a very direct approach with this. Follow the path of resistance. Okay, where does it not move? I help it move because that's what it needs more of. And then train the body in the range of motion. So, last little point of comparison, I believe, which is psoas and anterior spine. So from a functional manual therapy standpoint, we would say, okay, here's your psoas. If it's really, really restricted, I'm going to use a mechanical force to create a mechanical change to allow it to either lengthen or fold.
In an MSI approach, you're looking at an extension syndrome that's probably going to have not enough length to be very stiff, too stiff, and then in a flexion syndrome, not stiff enough. So you're looking at changing the relative stiffness depending if they have trouble flexing or extending. More from an exercise point of view, activity point of view, daily habit point of view, rather than a manual manipulative point of view.
All right, then for treatment, so we're going to have our pre-test, we're finding a comparable sign, we're going to go and treat all of those different things, which literally in the clinic can take less than 8 minutes, or here it'll take us probably close to an hour. And then we do our post-test, and we hope to have a change. It's going to be a little embarrassing in front of all of you if it's not. So manual therapy conclusion, basically we're going after the restrictions, we're going to go direct treatment, being specific, and then retraining that movement. Bob, you want to take that slide?
So, at the end of this, I'm going to be representing one camp, April the other. In actuality, we belong to both, which is kind of interesting. We have cards in both karate dojos, as I said before. So movement is to motor control, as the wind, as a boat is to a boat, as wind is to a sail. You need movement to get that boat moving. So it pushes the vessel into the direction. The boat is off course, the wind will continue to move it off course. Manual therapy is to a boat rudder, the thing that steers it, is to a vessel as, manual therapy is to a boat as a rudder is to the vessel, which means it can turn the boat back onto course, but it can't bring it back to port. So the combination of both manual therapy and motor control really gets that boat in the right direction and back to course. So at the end of this, you'll see how the marriage of both manual therapy and motor control, or motor control and manual therapy, gets the patient back to course, back to the port.
One moment. So, my other very grand, really grand idea on this is, all of us in manual therapy, in physical therapy, have a horror story about what the next clinic over did to your patient now that you're treating to fix them, right? We've got lots of stories. I'm sure some of our patients at Body Gears have gone out and gone and seen you, right? And you're like, oh my gosh, they don't know what they're doing there. Or we're like, oh my gosh, like Mickey, I mean, you haven't treated for a while, so it hasn't happened in a while, but those soft tissues to release as I'm retraining that movement of external and internal rotation at our hip sockets. All right.
You know the price has gone up to $200.
As well it should. All right. And I'm pretty happy now with what that's looking like. We said she's, did I say flex or extended?
The coccyx,
Yeah, right.
it was more right rotation with the
Yeah.
dominant, then she undulated.
Yeah,
You said it's.
yeah, because it should be, and I'm a little too high up then.
What's your comparable sign? What are you gonna test after this?
Functional manual therapy,
The test
the
and
testing. And I could do it just after doing this. Well, we can do that. Usually people have a pretty significant, usually like a 1 grade jump. So, do we want to? Anyone? Anyone? Okay, we'll do it. Just for the fun of it. Okay. You all right? Okay, stand back up, please. It was with the right leg, there was a 0, so that may or may not change that much. So step forward with the right leg. Good. Don't let me push you over. That's pretty better. Hold on, let me move you. She still falls back, but not as much. And we don't need to test this one because I was already a 5. Switch to the other leg. Hold on 1 second, because you just settled yourself. That's okay. So just step forward and stop. There you go. Don't let me push you. That's significant difference. Hold on, let me move you. And that's significant difference. Okay. So from a
Which side
functional.
were you treating? More the right side? And then coccyx?
Yes, right side
Okay.
coccyx and left side sacrum at the same time. Okay? So,
The treated dysfunction on the right side seemed to make the right side much better.
and seem to be able to, if you think about it from a functional standpoint, that right side, when I'm pushing her back onto it, is accepting my load and her load of her body, right? So if you're, and it doesn't necessarily work like this all the time, right side, left side. Again, you treat the dysfunction that you find, and then you retest for function afterwards. Okay, let's go face down again. All right, now, if she's a thin person, she's frail, she's afraid of me moving her, am I working this hard on her? No. If she's a big guy who, like Tony, this guy this week, who's transferred from another therapist to me, who's mouthy, I tell him, shut up, get on the table, and I start beating on him. He's like, oh, and he's making fun of my shirt. Whoa, what'd you get? It was a funny looking shirt, right? I wear funny clothes sometimes. And he, anyway, he was making fun of my shirt.
The ruffles.
The ruffles shirt. Okay, so now I'm looking at, for the sacrum. So it looks like I'm doing hip internal and external rotation, which I am, but that's not where my brain is and that's not where my focus is. My focus is I need to do sacral, left side, nutation, and counter nutation. And I'm just loading it up, so I'm not just doing this. Because that's what you do when you're a student, and you're supposed to, because you're still trying to learn, right? And you're trying to figure out, what is this feeling? Like, am I doing anything? And when you get to be you lift up, a little bit more experienced, then relax that down. Good. Now I'm going to block the innominate, get on that sacral piece that I want, pisiform. The rest of my hand's going to cover it. It's not doing anything. Pisiform here. And then, what do I need this hip to do? What can't it do on the board? It can't do external rotation at the innominate, so I think that's what I'm going to go do. Just to block it, help it move, right? Going into the restriction, very specifically, right? This needs to move forward so that this can rotate back. Move forward, rotate back. Hey patient, can you move please? So, she's like, nope, I can't. How about this? You can feel my leg right here? Can you just push into my leg? And then release. And push. Good, and release. Is that too hard? Because I'm pushing pretty good, you can see. Push. Good, and release. Good. Try and straighten your knee now. There you go, and release. Try and straighten it. Good, and straighten it. Excellent. Now I'm going to do counter nutation. Wait a minute, but you were just nutating it. It can't have both. It sure can. Think about a door, right? The door is stuck. can't close, it also can't open. So I'm not gonna just work on it closing, I'm not gonna just work on it opening, I'm gonna do both. Sacrums need to be able to nutate and counter-nutate, so I work both. That to me was a very hard concept when I first started treating. But if I need this, then I can't do that, right? Does that make sense? I bet a couple of you are staring at me going, but wait a minute, try it, see what you think. All right, from here, push into my handle, let me move you. So again, I'm doing sacrum, PA glide on the left side to do counter nutation right now, because I'm at the ILA, push, no, not here, push into my hand. There you go. Come on, push that. There we go. And release. Good. And push again. Good. And push again. Good. And relax. Excellent. Now we're getting a good histamine response. Just make sure that that's looking good, which it is. All right. Other things that are popping into my head are that I really want to do some femoral work, but am I missing anything else? Okay. So I can do an AP glide, which is probably going to do better for her than doing inferior first, because I want to get her on axis before I start moving it inside the socket. So I want to get her femurs backwards, in particular her right side. So can you lie on your back, please?
If I already checked the LPM on that one,
Yeah, sure.
on the left side back.
Yeah, you want to stand up again?
The right side back looks much better after the coccyx work, the left side.
Okay, stand forward with your right leg. Good, don't let me push you over. Ooh. Hold on, let me move you. And see, I'm coming on even quicker now, and she has a response. I still overpower her because she's not strong, but she has initiation, right? Initiation, strength, and endurance. We finally have it to initiate. Great. Lie under. Yeah. I decided I'm going to do AP glide. So here's where we kind of get into a little pickle when you're demonstrating. She's got a lot more soft tissue issue than I think she has joint issue, which is what is creating this dysfunction. But inferior and slightly posterior glide here. Is that okay? Mm-hmm. That's where your water ski techniques come in really handy. Ever so slightly, take your pubic bone, wherever you think that is, and pull it up towards your nose. Perfect. And then one more. Good, pubic bone up. Good, relax your left side a little bit. Okay, relax that.
Drawing her pubic bone up allows her to set the spine, makes it a little more stable, and allows the thrust to be more at the hip rather than through the spine.
That's about 50%. I'm not that excited about that. I'm not that impressed with myself about that. All right, let's do this one, because I know that was the much more restricted one. Actually, Bob, do you mind helping me out on this one?
Yeah. Good luck.
So there's different end feels, right? If you have a soft tissue end feel or a joint end feel, you can just do a slight distraction.
Tell me instruction.
Compress it instead. And her right hip feels like it gets even tighter, which is kind of is intuitive. Like, yes, if I lengthen something, it's going to feel tighter. Her body doesn't respond well to that up here, so I want Bob to actually compress the joint and give it some space so it can unravel itself, and then allow that joint to do what we want it to later. So I'm going to push the femur posterior.
Screen there.
So my left hand right here is gathering some of her tissues and pulling them towards her hip to create more space. My right hand is doing a anterior to posterior femoral glide. It's not real strong right now. It's probably like grade 2. Bob is doing a grade 3 or so, or depth.
Yeah, 50% into resistance,
Yeah.
if you want to call it that. Mm-hmm.
Into compression. And then, and then we're just following that direct line that continues to change as the joint is learning how to sit better into the acetabulum. There we go.
So what you guys can't see because it's sort of unsettled is she's starting to internally rotate and set underneath the socket. I can feel that pretty nicely on mine. And Kat, because we paid you off, you're going to say the same, right?
I feel fantastic. And then the other thing that I really would want to work on with her is some really strong pelvic dysfunction that I think she doesn't know that she has right now, so.
I had no idea.
I don't, I mean, we'd have to actually do an exam on that, but I'm not gonna tell you. Okay, now that feels better. Can you lengthen that out now? There we go. That's way better lengthening. Good. Does that hurt anything?
Actually, it feels good.
Feels good? Okay, good. So then we're gonna go a little bit more aggressively. So he's gonna create space so that I can push the femur down, okay?
Don't put me off the table.
So, yeah.
Push me. There you go.
So he's creating space. I'm gonna get on femur and just do a little oscillation to get go anterior to posterior while he's creating space in there. Think about relaxing the front of your hip and think about relaxing the back of your hip so it's got some place to move into. There we go. Nice. Okay. All right, and then, that's a pretty nice difference for those of you who can see that, right? So, and that's me stabilizing, not letting her compensate at all. If I let her compensate, she'd get her leg all the way to there. Okay, so I would expect my range of motion to be different after that too, right? But before I check range of motion, I really would like to do an inferior glide. Because we just worked on this side, I'm actually gonna have you turn head up this way facing them.
Am I coming?
On your side. Yep. And lift your head first. Like so. Bend the bottom leg up. Bottom leg up. There you go. Hold there. Great. And then, so, relax that. So, she looks like she's lifting her leg a lot higher, and you should all say, wow, but she's completely compensating. So, let's get her not compensating first. There we go. Okay, so from here, that still is pretty impressive difference. And now, so MCP is going to go posterior and inferior. I already did posterior, right, anterior to posterior. However, when I get her in this different position on her side, can you relax your leg? Thank you. Go. When I get her in that different position, it just loads up differently and it pulls forward, which is why I think she still has a little bit more lower abdominal, like inguinal ligament area restriction, which is pulling that. So, all right, so from here, I'm going to go inferior. Does it feel okay? This leg is lifting up to create tension to her pubic rami, all the way down, long adductors, plus her short adductors. I can then, oh, she's got some great restriction. By great restriction, I mean yummy for a therapist, right? I want after that restriction there. Ooh, is that tickly?
Yes.
Sorry. And may I touch the bone that you sit on?
Sure.
The sit bone? Okay, so her sit bone, which is right here, if I trace that, oh, so her hamstring on the backside is really restricted. Her adductors, Lord have mercy, do they need some work? There we go. And then you can see just from doing that, I'm lengthening this, I'm shortening this, and I'm doing an inferior glide of that femur. There we go. Now I'm not doing what we call muscle energy technique here, but I'm just taking her to her end range and saying, hey, adductors, you guys probably haven't worked here for a really long time. Let's work you here. You'll notice that when she pushes, this hand is going to want to pop up. So I'm not going to let it pop up. I'm going to keep it down. Okay, so very gently take your knee and pull it into my leg. There you go. And then I have to sink into that a little bit more, which increases my capsule direct restriction mobilization. Good. And relax. There we go. Taking that up a little more. Woo. Okay. So again, she's somebody, that's pretty nice. She's somebody who would respond really, really well to coming in every now and then for some maintenance treatment, right? Maintenance therapy gets such a bad rap. Everybody needs it. You take your car in, why don't you take your body in? Right? Take your teeth in twice a year. Why don't you take your body in? So maintenance is good. Other side, and then we're done. And I'll show you how we do it way faster on this other side. Okay. Other side. Bend that bottom leg, yep, keep it right there. That hand hold on. Good. I'm not sweating with all of my patients. So I'm sweating a little bit now, just because it's hot. All right, ready? So again, the last time was pretty gentle, because I've was assessing that that's what her tissues were gonna respond better to, of this side. Can you let that part release? Thank you. Good. Pull down, and release. Don't pull your abdomen down, pull your knee down. There you go, and release. Good, pull down, and release. Pull, and release. And then, other thing too is, you guys, I'm assuming are thinking, wow, she's touching her pelvis a lot. And we do, and that's because, even though she's not quote unquote a women's health therapist, that's where your hamstrings attach. So if you aren't touching the pubic bones, you aren't touching the actual insertion of just basic muscles. I'm not even talking like piriformis or levator ani. I'm just talking regular leg muscles, right? So make sure that you guys are, if you're not comfy with it, talk to someone who's a little bit more experienced about what's the language that I can use with my patients that'll make it so that I'm less awkward, so they'll feel less awkward. Okay. I think we're good then. And then AP, line your back. Okay, so here's for pubic symphysis with my left hand. I'm going to stay superior to that. I know that I want to get inferior to the umbilicus. And if you just look at my forearm, I'm coming around the corner. There's my guy, my gal, your gal. There we go. So now, I'm gonna start using, I love physics. I don't remember which lever this is, but I'm gonna use it. Anyone? Any students here? There's a student. You were in. One who's from, yes. Which lever? He's like, I don't remember. Extra credit points for anyone who knows. Okay, good. Now, take your tailbone, pull it down towards the ground. Good, and release. Good, take your tailbone, pull it down towards the ground. And release. Good, relax your abdomen if you can. Thank you. Do a little bit more there. Good, and pull down one more time. Excellent, and release. Nice, okay. Now stay back. Okay, so we haven't done the elbow flexion one, so let's go back to that one and see how she does. Just bend your elbows, just relax. Okay, and then don't let me straighten your elbows. Okay, so that's pretty nice. Now, I'm not happy with the fact that her elbows straighten, but she didn't fall over, and I'm not cueing her to do anything different, right? I said the exact same thing before. Don't let me straighten your elbows. So she's thinking about her elbows. She's not thinking about abdominal bracing. I've got to make sure that my foot is on, between my ball of my foot and my heel. I don't know, right? It's don't let me straighten your elbows. Right? I can fall on top of her almost. Almost. Relax for a second. Good. Bring your right leg in front. Don't let me straighten. So relax for a second. Okay. So yeah. Whoa. Okay. You good? Okay. Don't let me push you over. Don't let me push you over. Okay. So that one is not better right now for sure. Can you relax this area? Good. Good. Back up. Just relax. Good. Don't let me push you over. Okay. And hold on and pull you. That one was still fine. Other side. Don't let me push you. Good. And don't let me pull you. All those are looking much better. That's it. Except for that.
Yeah, leave something for me.
I know. Okay. Hold up here. Don't let me pull you down. Now look at that difference, you guys. That's impressive. Hold on, let me move you. She's someone who's got pain who gets in and out of a car. She has problems doing stairs. That is really substantial for her. Come back up. Hold on, let me move you. Nice. Relax. Let's relax. We're going to look at internal, external rotation. We'll start with the right. Okay, she's kicking her other leg now, and this isn't popping up at all. Internal rotation. That's really nice. External, again, moving her other leg out of the way. Relax. There we go. She still pops up a little bit right there, but again, we're at 40 degrees or so, 30 degrees. We'll take that. Lie on your, actually no, let's do extension. Lie on your stomach first. And I didn't even treat out a nominate extension, which shoulda, coulda, woulda, just didn't. So let's see if that's any different. It's substantially different. So 1, 2, this finger should move upwards, right? And it does. I don't need to check the other one.
So here's an interesting point. So Kat, do you mind hanging out here for sake of time? Because we could easily make this into an all-day event.
Oh,
But
sure.
we can't, 'cause we have to eat. Do you mind being the participant for the rest of it? Now, in our world, the marriage of manual therapy and motor control, that was the manual therapy. You guys get pretty appreciative of how much better she's moving. Now, if we send her off, she might be a lot better. She's moving more efficiently, but is she moving is the best control? Now, if you followed April around, she would do something after this. Because I'm also a speaker here, I'm going to do my thing after it on Cat. You don't mind, do you?
No.
Come on back up.
It's $300.
Alright. Deal, man. We're going to pay you $400. So we're going to go through, and Kat is already in lab clothes, which is fantastic. And April's going to chime in a little from time to time, but we're trying to see what is an MSI approach, what is a movement control approach, address this patient who's just gotten a lot more mobile. Because if we have mobility, it's like turning that rudder on a boat, we're headed back to course. Now for the wind, if we were to put the wind in that sail, it may not be back at course. So we're trying to look at putting the wind back into that sail and move it along. Sound good? Come on back up. So what do you guys see during the motion examination, any part of the examination that still is not comfortable in your stomach? Like, wow, April is really cool, she did a lot of great stuff, she's moving a lot better. But what thing is still interesting? Yes?
I'm worried about the learning effect, and now we've tested her 3 times on the same thing, and she's getting better each time without
Absolutely.
an effect of learning.
So I could wow you guys with doing the same test, or I could do some different tests. So let's do some different tests. Let's see here. So in the MSI approach, we would look at her still as an extension. Now April did anterior to posterior, she improved her hip, things are stacking better on top of it based on how she's much more strong with strength response. But as the learning effect, how do we hold on to this? All right. So how you feel right now?
Pretty good.
All right. Any discomfort in that back or hip areas other than just kind of gotten worked over?
No.
All right. Let's look at her appearance. Do you mind facing me? So you mind if I expose you a little bit? I won't expose your tailbone though. I promise.
Bob, side note, I still want to do lumbar extension at some point to check and see what changed, and I'm assuming that's.
That's what we do. I'll be doing that in a moment. Yeah. So before we do anything, we're just going to look at her mobility. You good with that? Mm-hmm. And you don't mind if I pull these guys up above your knees?
No.
So in an appearance, and in the handout, it's there. So let's just look at, relax yourself for a moment. Let's just look at what we're looking at here. Let's look at what we're looking at. So we're probably looking at maybe a little bit more extension, lordosis there. If I palpate, maybe a little bit more tone or contractility there. How about her hips? Her one hip a little bit outwardly rotated than the other. Are these inside both of their hips? Are they symmetrical? You see that? So like this part here, is she rotating a little bit more? Is she more on one leg than the other? Which one? Okay, so let's do this. Let's go ahead and flex forward again. Just bend forward. Let's just look at forward bending there. Come on back up. Alright, one more time and we're just going to hang out there if you can. So again, that curve reversal is a good bit better from April's motion, but it still maybe could be a little bit better, after just a few minutes of treatment. Come on back up. Any pain with that?
Yeah, a little bit.
Whereabouts? Is that your familiar pain?
Yeah.
Put your hands in the small of your back and just bend backwards. Okay. And that's a little bit better, April. Come on back. How does that feel?
That feels okay.
Okay, and no discomfort with that one. Okay. All right, let's look at side bending. Go ahead and bend to the right here. What do you guys think about that? Pretty flat. It doesn't take. It kind of takes the load maybe here, and then you go to the other side. Which is our better side? This side curves better to the left. The right side, it looks like it's a little less stiff. Is one side more uncomfortable than the other?
No, it is.
Which side is more uncomfortable, the right or the left there? Going to the right or going to the left?
More uncomfortable on this. Or no, this.
Going to the right.
Yeah.
Okay, good. You're going to keep your $300 check it. Alright, let's cross your arms and twist to the right. What do you guys think about that? And then back. Can you focus in on her from here? Okay. And then to the left. And then to the right again. That's an interesting little.
Yeah.
little catchy thingy. Alright. So we've got an idea of what's going on. Let's go lift up this left leg. See what happens in the hip drop. And then back. And then the other leg. And then back. So one more time. Which one's more cattywampus looking? And then the other one. We're looking for kind of bigger stuff. So when she's standing on the right side, it's a little bit more interesting.
Is she watching herself?
What's that?
Is she watching herself?
She's watching herself, I guess. All right, excellent. So let's decide which is our most interesting decision of those bunches. How are you feeling right now? What's that? Side bending? Side bending. Okay. Side bending to the right side. So you don't mind, we're gonna leave this up here. So let's kind of take the approach. We're gonna treat what she fails at here. So let's go to the right again. All right. Give me a pain rating, or you could look at range of motion. She's above her, about an inch above her thing. Come on back, and then she does this sort of interesting torquing. So come on back. So now April did not do her thoracic spine. If she did, she'd probably be moving easier from a manual therapy point of view. So from a MSI point of view, let's stop where she's moving, which is probably here. And that's kind of where her symptoms live. Is that right? So I'm going to stop where she moves. I'm just going to give a nice big bear hug. So movement systems impairment therapists do manual therapy. We do put our hands on people. Let's go ahead and move to the right. Just go ahead. Yeah, yeah. So I'm going to block where it hurts. And come on back up. And again, you guys seeing it? Okay up there. Go ahead again.
On the other side?
No, just to the right. That's the dysfunctional side. And then back. If you had little glow-in-the-dark markers, that'd be nice. Go ahead again. Good. Let's do about 3 more. This is a movement thing. So if this is important for her, this would be her exercise. How would she block herself? Symptom, or her hip, that's a little different story. Maybe wedge against something so she could use that to move more freely. One more time. I can't count. I'm a physical therapist. Very good. How are you feeling right now?
Okay.
Ramping up at all, or is that more your thoracic spine?
No, I still had something.
Okay. That's for our other class next year. She has to come back for that class. I'll record it. All right, so let's repeat. See what happens. Go ahead and move to the right then again. How's that feel?
A little better.
Okay. And then back. One more time. Let's look at, no, just to the right.
Oh, I'm sorry.
So she got a little bit more motion, and she's not torquing there. So that's an important thing for her. All right, how about the standing? Go ahead and lift up your left leg there. Or, yeah, left leg. Does that change at all? It might, because she has a little bit more mobility. Come on back. Now let's do this for me. I'm going to put my hands in your belly. Is that okay? Tighten these guys a little bit. Just give me a little tight. Right here and here. I'm asking her obliques to come on to stabilize her pelvis. Good. Now she just flattened her spine out, which is interesting. Now back to April's comment about, do we do this constantly? Well, no. You have to build up the passive stiffness over time. She's got a lot of length up in here. She needs to get these guys toned up. So tighten this up a little. Good. Now lift up your left leg. And then down. I'm giving her a lot of feedback with my hands in the wrong place, but this is what I want to tighten this one up. So tighten it. Good. And I'll lift up the leg. And then better. Good. And then tighten it again. And lift up the left leg. Now how does that feel that way versus don't tighten it, just do your normal way?
Feels more of a stress function.
With what? With or without?
Without.
So with, you have a little bit more stability there.
Right.
Now, if I'm running out of time because the lecture...
A double mastectomy 2 years ago, so
Okay.
I have a lot of tightness and pain up in here.
Okay.
And so since I do boot camp and weights a couple times a week,
So she does lots of push-ups.
so I kind of strained my
Okay.
back and that, but I do always, there I said I have really tight hips and stuff, and I do have some lower back pain because I also work at the computer all day.
Okay. So she sits a lot. She does boot camp, which I would like to find out a little bit more about what she does with that, because that could be pretty key with what's going on in her hip. How long have you had the hip stiffness? Like, did she take a new job? Did it start from that? Or, I don't know, I just feel stiff. I had a fall.
Lower back pain probably off and on for years.
Okay. Like most of us, right? Okay. So off and on for years, and if on a scale of 0 to 10, what number would you put it at?
It's about usually around 3 or 4 normally, just even sitting.
Okay, and where are we at right now?
Now it's 10.
Yeah.
Next.
Bob, you're up. So we always joke about that when we have students, you know, and they think we're being very serious, and like, so what happens when a patient does such and such? And we're like, you refer them out. So no, not that time. At least take a crack at it, right? Have your colleagues take a crack at it, then you can refer them out. Okay, so usually about 4. And are we having a typical day, or are you more flared up, less flared up than usual?
Actually, it's better this week because I've had a lot of manipulation on my back and stuff, and I think it's loosened up a lot.
Okay.
So,
And do you mean manipulation actually somebody popping it, or do you mean manipulation somebody working on it?
working on it.
Okay, and sometimes you want to find that out, right? Because if it's actually grade 5, and you know they do well with that, and you aren't good at those, then either you need to refer to someone who does those, if your treatment isn't working for her, or find out how to do them, take a class, right? Okay, so, what are the other things that I need to know about you for right now? Any neurologic symptoms that you know of? Numbness, tingling, your foot kind of drags on the ground accidentally, or?
I do have some numbness and stuff down this arm.
We don't care about that. This is lower extremity today. Yeah.
And I am fine.
Then I'm fine. Okay, good. So now that as I'm going through this eval, and obviously we're looking at lumbar-pelvic and hip today, but I really should be thinking to myself, like, she does have significant issues, and if she's being treated by somebody, fantastic. Hopefully she thinks it's going well. If I am seeing that it's not going well as another therapist working with her, let's say she's going to massage therapy, right? I'm not going to badmouth massage therapy and be, oh my gosh, I can't believe you pay for that. That's terrible. They shouldn't even be working on that. They don't have a degree for that, right? Which may be all true, but you don't present it to the patient that way, right? Because then we look like we hate everyone else. So instead of that, we say, wow, so you really like your massage therapist? Yes, I do. I don't even know if you know a massage, but yeah, I like my massage therapist. What do they do that you really like? Well, they do this part of it. Oh, that's fantastic. You know what? I'm treating you for your hip and your back. I actually could do this part for you also, in addition to the massage that you're getting. I also look at what does your rib looks like, and how does it interface with your thorax and your thoracic spine. And if you're interested, I'm happy to do a free screen on you to find out if we can do anything else, right? So again, as a bigger picture therapist, that's what I'm looking at. From a MSI versus IPA FMT, what I'm thinking is, I'm so glad that she's got stiffness because I want to work on her mechanically. Okay, so the very first thing is, and I don't usually do this in this order, which is why I'm going to use my notes here. So a functional test, there are 3 of them that the IPA teaches. Stand up for a moment. What I really want to look at, though, not one specific joint or one specific muscle right now, but how does her body respond overall? When she goes to step forward with her right leg to push a stroller or a grocery cart or open a door here, how does her body respond to that? So let's actually turn it over here. There we go. And then step forward with your right leg and just settle there, like you took a step. Good. Now I'm just going to be that force for her. Don't let me push you over. And you can see right here, she breaks. Relax everything. Because it's not a preset, it's a reaction. I want to see how does she react to, not preset and brace for. Don't let me push you. Ooh, that's very interesting. We have triplanar dysfunction, right? Where she's not able to maintain that force, and even if I come on slowly, I can still push her over. And I'm pushing about with one finger, okay? And she's been instructed, and I believe that she knows what she's supposed to do, that she can't hold that, okay? So now, don't let me pull you. Well, that's solid. I can do water skiing on her, right? She does very nicely with that. Good, now switch legs. Good, and don't let me push you over. And now, much more sagittal plane dysfunction, and we don't want her to be doing that, right? Obviously, that's very dysfunctional, and that's creating, I would assume, part of her problem, right? Hold, don't let me pull you. Now, not as solid. If you guys over here can see her pelvis is shearing to the side, you can't see it from your angle. But I wouldn't be real excited about her opening a door. Let's say she's holding something and trying to open a door backwards pushing, okay? And then, relax everything. There we go. Just bend your elbows like so. And what I want to do now is see how does she respond when a weight is applied externally. Don't let me straighten your elbows. And you can see, not only does she lose her balance, but she comes forward quite a bit, right? Don't let me straighten your elbows. Now here's the fun part. No, really try. Really squeeze her. All right, because so now here's what we're going to do. I'm going to tell her to abdominally brace. Activate your transverse abdominis. Come on, get that. Okay, ready? One finger, I'm gonna break her. Don't be straightening your elbows. Boop. And she's even worse with that, okay? So, from a certain standpoint, I won't go through all of the science that goes behind that, but if you have somebody actively brace into it, not only does it make them so rigid, it also makes them unreactive. Okay, so we've got different things that we would do to treat that. So my functional test now, lumbar protective mechanism, when I push her and stagger stance forward to backwards, does she have a good protective mechanism for her spine? Not so much, no. When I pull her, wow, is she strong. When we switch legs, again, not so responsive, right? Very sluggish. She gets back to here while her facets are closing before her muscles go, oh, and you need me? Okay. So that she doesn't fall over. Same thing when I pull from the back to the front. She stabilizes much better than she does front to back, but then she starts to get weak and her pelvis goes out to the side. Okay? Then from an elbow flexion standpoint, how much weight should she be actually carrying? If she's a male carrier who's got like a 40-pound bag, that's a big problem. Or she's a waitress. Huge problem for this person, right? And so we have to figure out what to do with that. Okay, yes?
Pardon me. Yeah, what motion bothers you more generally, bending forward or bending backwards?
Bending backwards.
Okay. So you guys who are on my team in the MSI system, she's demonstrating the extension syndrome. Now, again, we can treat it in both, and we're going to in quite a bit, but if you remember back to my slides about extension syndrome, because of her postures and things that make her a little bit worse. But extension syndromes generally have the strength in the back and the weakness in the front, and they have that muscle dysfunction. So just back to April's talk, and we'll go from there.
Yeah, and would you do me a favor and just put my stuff on that side?
Which side? Oh, this is your stuff.
Oh, that's fine, okay,
Yeah.
so then put, I want, 0, comma, so you know, all 4 numbers in a row for RPM.
Okay.
So, 0, 5, 2 minus, 4 minus.
April, I have a quick question.
Yes.
And maybe you'll get this later, but what are you differentiating between when you do the bicep test and the pulling on her shoulders? Because you're pulling her forward both, and her spinal extensors are gonna stabilize on both of those motions.
Right, and
So
I
what are you
didn't actually differentiate that very well for you. I'm not actually pulling forward, that's why I got all the way down here, because I'm applying a vertical force to her forearms. So although I am in front, I'm not pulling her forward, I'm pulling her straight
Okay, but
down.
the lever arm is still gonna be forward.
The lever arm is still forward, yes, and so what should be happening is that her core activation, or
Right.
core first strategy, front and back, settles that weight through every single joint, you know, thorax, ribs, all the way down, into her acetabulum and in the femur, all the way straight down through into her arches. So that's
So
what's supposed to be happening,
theoretically,
theoretically.
Challenging her lower core, while when you're pulling on her shoulders, you're challenging her spinal extensors more?
Right, and so this is why I'm saying I don't necessarily wanna go through specific muscles, because
Right.
when I'm pushing her, it's the entire front and in the entire back, right? It's more
Right,
the
but you're
mo-
biasing.
Right, and it's a motor pattern as opposed to a specific muscle. So that's why it's a movement test, not a specific manual muscle test like to elbow flexion test.
Right, I guess it's theoretically in your brain, what are you differentiating between when you do that versus that? In your mind, where do you start to go?
Thank you. So if I'm going from the front, I'm looking at how does her body load horizontally. When I'm doing this, I'm seeing how does her body load vertically, and I could even just take her arms out of it. Stand up for a second again. If I just take her arms out of it, how does her body load vertically or vertically compress and test it that way? And then I can just add how does her arm, as in humerus, scapula into thorax, how does that interface then with the rest of her body? So that's what I'm looking at. All right, and then, so we've got an active range of motion testing. Come on up again. And so, let's go sideways here. May I lift this up so we can see her back? All right, so from here, active range of motion. I'm not even gonna tell you about posture and, ooh, this is too high or that's too low or anything like that, because right now I don't really care. I just wanna see how she moves, right? Scoliotic people, I'm never gonna get them to be perfectly aligned, right? But I can get them to maximize their movement. So, bend forward all the way as far as you can. And she's very flat, and then at the very end, she's ever so slightly rotated to the left. And then come on up, and then bend backwards. And she bends at her knees pretty nicely. Come on. Good knee bend. Okay. Her knee and her neck are fantastic extenders. Okay? Wonderful. And then I can do side bending and that kind of thing. I'm not worried about that. That's really the biggest thing that I need to look at right now is forward bending and backward bending. Okay, have a seat for a moment. And let's take a look at her actual hip socket when it's in flexion.
So you have a
Yes.
painful extension and no curve reversal?
So I, as you know, don't even write down if it's painful or not because I don't care because most of our patients are chronic pain. So everything hurts them. And they probably have homunculus smudging. So if I touch them here, oh my gosh, my back hurts. So it doesn't matter to me what movement produces or doesn't produce pain. I'm looking
Limited
for efficiency. So I would say, so I'm going to give it a percent. So forward bending, I would give it 40%. And it demonstrates rotation left.
Okay.
And then extension, I'm going to go like 10%. Okay, lovely. So now let's look at, if I don't let her entire body rotate, and if I only look at the hip socket into the acetabulum, relax that for a second, don't help me. Don't help me. There we go. So external rotation and flexion I'm not too worried about. Well, internal though, ouch, and now watch what happens to my hand. Oh, it really pops up. Can you guys see that on the screen? Pops up. If I do this side, so we've got internal rotation dysfunction on the seated internal rotation. External rotation looks lovely. Internal rotation, not so bad. Relax that. Just make sure. And internal rotation is also a little restricted on the side, but not nearly as bad as I was
Right more than
expecting.
left.
Yeah, right more than left. Okay. Now, does that mean that I'm going to find the same thing when I put her prone? Probably not, right? Because that's a completely different position, completely different tissue loading. So lie on your stomach, please. And put this down under your abdomen. And then this under for your forehead. Okay, so again from here, I'm going to look at just how does the femur interact right now with the acetabulum. So when I palpate, internal rotation looks fantastic. Oh man, external rotation, not so great. So if she's someone who walks a lot for her job or stands a lot for her job, she's in a lot of trouble because she already has mechanical restrictions when she's in I know we're prone, but she's in a standing alignment, right? She just happens to be 90 degrees tilted, right? Awesome, okay. I heard everyone say yes in my head. Okay, right, and then external rotation at the hip, really not that restricted, but internal rotation, definitely right there, doesn't move anymore.
And that match is sitting on the right side.
But
and
opposite on the
prone-
left?
Prone is more dysfunctional on the left.
Okay, so, and Bob, can you just turn the skeleton on? So now what I'm gonna do is look at external and internal rotation of the innominate. So if I look at external and internal rotation of the innominate, that's what I'm looking at. I've got one finger on the sacrum, I've got one finger on the innominate. I'm going to see, do they spread apart or not? Speaking of buttocks, there we go.
You can close up on that one, April, or you good?
We're good. So, relax that. And she has a little bit of external rotation, but it doesn't move forward like it's supposed to.
It moves at the spine.
It moves at the spine up here
Okay.
instead.
She also goes into hip flexion.
She also goes into hip flexion, exactly. Right, and so here, relax that. Oh my golly, yeah, her innominate doesn't move at all. I don't know if you can see this, but my fingers are literally not moving. So her innominate doesn't externally rotate. Right there. Does it internally rotate? Man, that side's really stuck. I don't feel it on either. Then I'm going to put my fingers at the SI joint, and I'm going to say, do I get innominate extension or anterior rotation? By anterior rotation, I don't mean that I'm increasing lumbar lordosis. I'm not worried about that. It's not even part of the joint that I'm assessing, right? I'm looking at, does the PSIS move superior? Here's the sacrum. Does the PSIS move superior and rotate off of the sacrum? And none at all. That's all femoral extension right there. And then
What are you
this.
feeling on your finger there?
There's just a lot of stiffness. And then, just watch this one now. That one extends. Can you see that? Stiffness. Don't you, I said that word. I didn't mean stiffness. I meant restriction. Right, so watch again. Watch the difference between these two. So I can't budge anything. I get stuck. The door is not opening or closing right here. is just stuck. But you can see her hip is moving up and down because I'm getting it from her hip socket, femoral extension. But I'm not getting any anomaly, okay? Yes?
And you said your fingers are on the sacrum, but are you also
So I'm actually right in between, right here. So I have, surface area on both the PSIS as well as the sacrum. You can feel that. May I touch your tailbone?
Sure.
That's
We're
what
my
I was
friend.
You know what is really funny? I asked her to volunteer for this without knowing that she was going to have her coccyx evaluated. No pictures of this, please. Thank you. Okay. So.
A little informed consent goes a long way when you're touching people's tailbone.
Yeah, right?
Kind of show them what's going on and the
Okay.
picture of all the muscles that attach, and
Yes.
they're like, oh, okay.
Here's Grey's Anatomy. So, for her tailbone it's in a position of right rotation, and it doesn't spring well into left rotation. Okay? And then I'm going to check her.
So it's twisted. This
Yep.
way.
And the other interesting thing is,
Oh.
sorry, she has a couple of different, it's kind of like a little roller coaster. So there's one part that extends, another part that flexes, and that spacing in between the two isn't very pliable. So I would say for her that she has an extended coccyx, and it's not flexing very well. So she has a flexion, joint mobilization, but restriction. Okay? What else am I missing? Femur, AP glide. So lots of different ways we can do that. I can block the femur and push the innominate, but then in my mind, I'm doing an anterior innominate glide, right? So I'm going to have her flip over onto her back. You do like this one? And I'm just going to allow gravity to be my stabilizer and her innominate. Relax that. And I just want her to release everything. I can test her in her normal lie down phase, but I'm going to try and mimic what I remember from her standing. That's closer to what she does for standing. And fairly limited there. I could also block her innominate underneath, which I think I'd like to do because I think it's going to show you a little bit better. There we go. And she has a much, much stiffer end feel when I do that. I'll do it on this side as well. Thank you. So, this side is really stiff. Yikes, really, really restricted. Right? And it's more so on the upper portion than on the lower portion of that femoral head. I can also block underneath the innominate and do the same thing. If the patient has a preference, then it can be up to the patient. Okay?
And if they're squirming a little piece of foam, it does wonders.
Yeah. Line your side facing that way. And then I believe this is the last thing I'm looking at. Line your side flat. Oh no, sacrum, I forgot notation and
Yeah, AP. Yeah.
I'll do that too. Yeah, AP.
Back on my
No,
side?
line on your side is great, since we're doing this. I'm gonna have her bring her bottom leg up. She's gonna hold it with this hand. That way that I know that her lumbar spine isn't gonna be involved with this motion. I'm gonna take her up into relax. As much actual abduction as she can get, which is not a whole lot. Relax that down. If I don't let her compensate at all, that's what I've got for abduction. There is a really strong pull. So then if I do my inferior glide, watch this finger, that's what I've got. Greater trochanter right here. I'm hooking on top of it to get it to move in that direction. Inferior glide. Oh man. That's really, really tight. And we do the other side as well.
I'm a mess. I'm surprised I made it here.
How are you breathing?
You're actually not a mess, you're just filled with opportunities to get better.
That's why people love Bobby. And I'm like, yeah, you are. And for camera's sake there, wow, that's a great picture. Sorry. Appreciate please how much more just osteokinematic motion she has. And now let's appreciate how much more orthokinematic motion. Here it comes. There it goes. Right? Much more osteo as well as orthokinematic motion in a inferior glide. forgot to do sacral nutation and counter nutation. Let's go on your stomach again. We have a handy dandy little half foam roll that's cut out, so the pubic symphysis rests right there. And then it blocks, there you go, it blocks the ASIS. So I'm not just doing this into a table, going, I don't know if I can't tell. You can't tell if it's moving or not. That's right, because you're moving the table. That's why you can't tell. Students are so good with that. I'm not sure. Okay, we'll help you. All right, so sacral base. I can do a couple different ways. I can just go through my fingers like so. I'd like to use a dummy thumb, let it relax there. I'm at the left sacral base.
You still left?
Yeah, where's the left?
Length consider.
There we go. Okay, so I'm looking at nutation on the left. That's fairly stiff. Nutation on the right actually moves pretty nicely. Does that feel more stuck to you on the left side?
Yep.
So look at that, super stiff. Relatively nice nutation on the right. Counter nutation, I'm going to go down to ILA with my right thumb and counter. Got a squish test, so we know that's not comfortable for her. And it seems that her left side doesn't like to move a whole lot because her left side is also not wanting to counter nutate. Okay? Lastly then, lie on your back please.
What was the major dysfunction? Mutation
Nutation
on
and,
the left?
it was actually the left side nutation and counter nutation. All right. Now here comes the fun part.
It gets better?
It gets better. I thought the tailbone was fun. So what I'm going to do is just go around your organs and just go all the way straight down to the front of your spine and press on that. It tends to be a little uncomfortable, so if you're too uncomfortable, just
So
tap
you guys,
out.
if you want to look up at the skeleton
Okay.
right quick.
Thank you.
So we're going to squeeze all the organs, which are little hollow tubes, unless there's some interesting stuff in them. Anyways, April is accessing the anterior aspect of L4, L5, and the discs to see why she's extended. Why is it she extended because she can't fold here, or because it can't lengthen on the back?
And people will tell me all the time, you can't do that. But you guys, this is as deep as her body goes. From the bottom of this, I'll put my hand underneath it because she's slightly lordotic, and from there, and now hand across to my thumb, right? So that's all the deepness I have to do to get to her entire back side. If I now transpose this on top of George, spinous process, can you just hold on? Spinous process to there, I only have to go a couple inches to get to her anterior body. It's not that far, okay? Obviously, she's got more soft tissue, adipose tissue. Yeah, it's a little further in, but it's only a couple inches, so. All right. That's a fun stuff to do. All right, so.
April, can you expose her belly just a little bit for camera's sake?
Yeah, for sure. Did you use that?
Sorry, Kat.
Okay, bring your legs down for a second. You just want to show your belly. She's had some other surgeries here
No
too.
pictures, please.
And so I'm just going to bring her legs up to give these tissues a little bit of slack. I'm going to have her move over towards me because my arms aren't long enough. Just scoot your whole body over. There you go. That was just my knee. Relax. That does happen though, right? Like you're working on a patient and your knuckle cracks, they're like, oh, I feel so good.
Yes.
I let that one go. Yeah, that was before I knew how to do manipulations, right? Okay, so relax that area. There we go. Now, she's got some other pressure system things going on that are going to make it a little bit challenging. Pressing it down there. Are you still okay? Okay. So, belly button's L3, right? If you're about an inch or so below that, you're at L4. If you're just above pubic symphysis, you're at L5. So I'm just going to sneak my way over there. And, yeah, L4 is pretty uncomfortable. L5 is really uncomfortable. And we get this, please stop that. Okay, so, and that's all I need to do on that. If I'm going to do treatment, I'm doing a lot more. I'm doing soft tissue work on that. I'm doing clearing out all the mechanical things superficial to it, so that I can get down to that area and actually affect it. Then the fun part is, at some point, I can use my tibia now to lift her femurs up, and now her sacrum and innominate are now weight bearing, and I can actually press nicely on that. We'll get to that later. Okay? All right. And Bob has left the room. I was about to say, and now, Bob, what would you do on this patient? So do we feel like we have a pretty good understanding? I'm just gonna write down all 5 on this. Okay. So pretty good understanding of her restrictions so far? Okay. So let's actually go ahead and start treating them real quickly and just see what we find. I'd like to think that I'm gonna make some nice changes on her because she is so restricted. Okay, so we're gonna go back to tailbone first. Oh, you know, we didn't do strength. Let's do strength real quick too. We didn't do any specific strengthening. Hold, let's see, leg up. Lift your leg up, right there, hold, don't let me move you. And watch her whole body, not just her leg, but watch her whole body response. That's really what I'm looking at. And this one, hold. Whoa. Really restricted on this right side. Good.
I'm just doing this to show you guys that.
Beta muscle test, right hip flexor, 3+. Don't let me move your foot out. Good, don't let me move it in. Ooh, left hip internal rotation, 4 minutes. Hold, don't let me move you. And hold, don't let me move you. And same thing on her right side. Okay, now let's go treat.
Oh, external rotation?
Externals were, she's always every time. So
Okay.
just don't let me write those down. I need my face down. Okay. So here's the fun part, right? So we're going back to your tailbone, is that all right?
Sure.
Okay.
Do you always start at the elbow and find that, all that?
So, most of the time, yes. If I don't know the patient, they don't trust me, I have a weird vibe about the situation, minor, none of those, right? Yeah, so can I go right there?
Yeah.
Okay. So then what you'll also notice is, remember we had, and again, we talked about joint, like we haven't even talked at all about her soft tissue restrictions, but I'm gonna go and clear a little bit of the, remember that picture of the back of the sacrum and innominate with all the ligaments? I'm gonna go and just clear some of those at the same time that I'm doing this joint work on her coxosacral junction. Sacrococcygeal junction. And here we go. Do I do the movement part?
Yeah.
Okay.
So in IPA world, the functional manual therapy, we do manual therapy with movement. A little different than Mulligan, but anyhow. So we do motion enhanced manual therapy.
So what I would then say is I can pick from any different movement pattern that she has that I know she's dysfunctional, because I know that's probably what her retraining needs to be, right? So if we look up on the board, we could say rotation would be a good thing for her femurs to learn how to do again, right? And I'm creating more movement at areas that are restricted so that those areas are going to learn how to move as well. So this is not muscle energy technique where I'm trying to do the opposite. I'm trying to actually, because remember, with functional manual therapy, it's move into the restriction. All right, so can you take both heels and just gently roll them together? Thank you, and release. Good, and roll them apart all the way. Good, and roll them together. Here we go, and apart. And then the fun thing is, after you've been treating for a while, can you just keep doing that? Right, you can start talking about, how's your weekend, and was the pool fun, and did you like Revitalize when it's great? Right? Or I can just say, hey, I'm only going to give myself maybe 10 repetitions of the same thing, and then I can move on to the next thing. And I can clear a whole lot of tissues, which is why I'm telling you sometimes it only takes 8 minutes to do everything that we just did on the board. All right.
So where were your hands on?
So I'm on the sacrococcygeal junction. So the coccyx is rotated up like this. I have my thumb, or whatever I was using, to get it to rotate left. And then my other hand is on the sacrum, the SI border, and getting, oh my gosh, Mickey couldn't get this person better. She should have done this, right? So what my grand idea here is, instead of us fighting amongst ourselves in just, treatment to treatment, we also shouldn't be fighting clinic to clinic. We refer people not only to one another within the same company, we refer people out to our competitors. And we do it on purpose, because sometimes we just don't have the skill set. Like, we do phenomenally well with 98.99% of our patients. And the other 0.1%, it's not up to me, even as the owner, to keep that person in my clinic just so that I can charge that person. It's up to me to not let PT fail for yet another customer. It's also not up to me to refer that patient back to the doctor. I don't know, we tried our best. They're not doing their home program. Okay, maybe they're not, right? Maybe that is the problem, but don't send them back to the doctor yet. Who should you call? A specialist, or a competitor who's a friend of yours, who works at a different company, right? That's who we should be calling, and not letting the doctor be in control of where that patient goes. You've got friends. You know who likes to treat hips. You know who's really good at it, or women's health, or necks, or whatever it is. Call up your friend. Hey, I'm in a pickle. Number one, what should I do? Try doing these techniques. Okay, if that doesn't work, what should I do next? Well, maybe we can meet over the weekend and just chat about the patient and I can show you some things. That'd be great, right? We're trying to revitalize our profession and not drive it into the ground, right? So let's let Illinois be a place where we refer to our competitors. Because when you pat them on the back, it might be a while, but they'll turn around and pat you on the back too. And the biggest thing is, if that patient is sent back to the doctor, and then the doctor sends them to your competitor, who gets the kudos for sending them to the competitor? The doctor. So who has more affinity now for the doctor? The therapist and the patient. Why wouldn't you be the one that gets the love, right? Give them love. They will love you back, right? So the way to build our community is to respect the differences, and the way to build our community is to encourage the differences to be there. Total cheesy thing. Have you seen the Android commercial, Be Together Not the Same, the rock, paper, scissors one? I love that one. And I don't even own a television, okay, but I saw that. So the rock, paper, scissors Android commercial, at some point in Revitalize you need to see it, right? Because we will, you know, there's lots of enemies at this conference, and we're all sitting at the same table, right? To the big national providers, to the teeny tiny little people, to the, well, I can't believe you work in a hospital, the people who still work at POPs. Who cares, right? We're all physical therapists, and we need to get along and start referring people to one another. This is a great microcosm on how to do that and how to literally put that into practice. Because if we don't refer to one another, those people get sent out after they failed to, at the second PT place, where they're gonna go? To a personal trainer down the street. PT couldn't help me. Thank God I got the internet for these exercises. Now show me how to do them. Right? That's exactly what happens. Or, after they failed PT a couple times and the cortisone shot didn't work and the patient still doesn't want to have surgery, I guess I have to go to massage every week for the rest of my life. And then we all say as PTs, nobody wants to pay for therapy. That's because you pushed them out the door and you put them in the hands of a massage therapist who's willing to ask for money from them. That's a whole other topic. So, back to this. Should we take a break?
We do. So the next thing, we want to advance the slide there. Before we take a break, any questions about the lecture material before we go on to the lab material?
I have just a question, if you have seen this type of case since you work in Monroe and,
Yes, every day.
yes, okay, so scoliosis in idiopathic cause in an adolescent. Have you treated that and have you gotten results from that?
Okay, so that's a whole loaded question. I would say with some scoliosis isn't necessarily just a mechanical issue, it's really the nervous system that's closing down on itself. And if you treat the coccyx and you treat the specific tube dysfunction as it goes up through the spinal canal, you can get immediate results. Do they always stay that way? That depends on if the patient then continues to use it. If there's actual wedging, of course not. That's different, right?
But with wedging, I mean, there's dysfunctions that go on around it. You can
Yes.
start treating ribs, soft tissue between the rib cage. You can try treating away from the area, and then you can just train the muscles to take stability
That's
or
what I'm
off of it.
saying.
So yes, it's not something that I say, oh goodness, a scoliosis patient, I'm not going to treat you. I'm going to say, let's see what I can treat and what I can't. And generally, if you treat what you can treat, you're going to get a decent result. I mean, maybe even a phenomenal result. But this is where the marriage of both manual therapy and motor control is essential. You do the manual therapy only, you do the exercise, no. So that's the, you need something to get length and then something to keep.
Because it's like if you have a car that's involved in an accident and it's got alignment issues, either in the actual driving mechanism or it got crinkled on the side, just driving it around is not going to fix it, right? So you'd actually have to take it to a mechanic to fix the alignment, which then changes it, right? Or you would just say, all right, it's terrible at turning left, I guess I'll just keep turning right. Hopefully it fixes. Okay.
It's manual therapy bias.
As I know. I have to leave them with that on the break. Okay, we're gonna take a 15-minute break. We're gonna go verify who our subject.
Line ends in 14 minutes. No, we have 16 minutes. We're good. I've got 2 little techniques I could send her home with. Is this the most important thing? Well, if she says, every time I stand on this leg, it really bothers me, I might stop and say, let's do these a lot. See me in a week. See me in a few days. Let's do these a lot to power these up. But I'm really concerned that she extends quite a bit still through that leg. So anyhow, failed tests become the treatment, and we do a very precise activity. Go ahead and face the window there. So we appreciate that she still has a lot of extension. She doesn't have that ability to be on top of herself. So let's go ahead and just draw those external obliques into it there. So let's just think about the elbow flexion test, just to see if she needs a little less length there. So go ahead and flex your elbows up. Good. And don't let me straighten your arms up. Keep it there. All right. Now go back to your normal way. Good. Arms up. Hold there. Don't let me pull you down. So I know this is a can test, and you guys are like, Bobby, you're full of it with this one. But what happens is if she's in a better alignment that April just put her in, but we maintain that alignment by drawing in these muscles that are too long. This is that loose spring here. This is the tight spring. So we have to get these to loosen on this side and these to tense up on this side so that you have more readiness of that hip. So this is what we're doing standing. Let's go to sitting. Have a seat. You still doing okay down there? So the hip, in sitting, we saw a couple things with April's assignment assessment that are interesting. Inter-tester reliability aside from the fact. Let's lift up this left leg here. Hold me there, don't let me pull you down. Okay, and again, a lot better from April's work. Let's see the other one. Don't let me pull it down. Okay, but can we get it even better than that? Come on back down for a minute. So let's flatten this down a little bit, get your alignment there. Again, something that we do in IPA land, functional manual therapy all the time. But let's draw these guys in. Again, you need some more contractility to these obliques. We'll hold that guy there, good. Come on forward a little bit. And at the initiation, this is a bracing technique. But as it builds strength and length in the sarcomeres, the muscles will be ready to go. Bring this leg up, hold it there, don't let me push you down. See the other one, draw those muscles in. Now, hang on one second. So you guys didn't get to appreciate this. Relax for a second. Her habit pattern is extending. She's a classic extender. When I asked her to do it on this side, she was good because she was turning on the right muscle sequence. When we did the other side, just go back and do your other technique. No, don't think of it. Just do what you normally do. Lift up this leg. She'll extend back. So come on forward. Tense these guys up, get the contraction going, get that length tension relationship more efficient. Leg comes up, hold it there, don't let me push you down. Feel any difference?
A lot different.
A lot different. So after the manual therapy gets the joint moving properly, you turn it on. Home program, what are we going to do? And again, I don't give 1,000 exercises. Maybe just drawing in the muscle and doing leg lifts. Can you do that at work? But you have to do a lot of them. Not a lot of exercises, but a lot of one particular, a couple different exercises. So let's look at hip rotation as well. This looks a lot like what April just did. I'm just showing you how the marriage are one to the other. Like, the wife cooks the dinner, the husband cleans up, or vice versa, whatever. In April and I aren't.
You cook, I clean.
Okay, great. My wife can't cook, or clean at all, she can cook, but. Alright, here we go. So I'm going to look at, what was her more dysfunctional side? Probably the right? I can't remember. Whatever. So bring your leg up like that. Hold it there. Don't let me push you out. And again, before April's good work, this was relaxed. This was a lot weaker there. Hold it there. So in MSI, we're really concerned about the hip lateral rotator. So the right one's weaker than the left one. You appreciate that, right? Look at a hell yeah, right?
Yeah.
Hold. Good. Relax. Or heck yeah. Hold. Alright, so this one is breaking better, worse than the other one. Draw on these guys, draw on those muscles there. So what I'm doing here, my lecture was like 3 days ago, right? You can't even remember what I was talking about. But draw these guys in. What that does is stabilizes the pelvis, so the prime movers of the hip, keep it there, don't push it out, are a lot stronger. Drop the contraction, just let it be, hold it there. So right now our hip rotators become the stabilizer rather than draw the obliques in. Obliques become the stabilizer. Draw those in, hold it there. It's more powerful. So I'm really concerned about making sure that after you get the motion from the manual work, we also draw in the specific technique. Not generic exercise, although there's a ton of research out there that talks about generic exercises that make back pain go away. But I'm really going to go out to the limb and say, we got to be very specific and give them 1 or 2, maybe 3 things, be very specific about what they do, and they do a lot of it, and they practice to be perfect with it. Okay, on your back, please. Anything to add there, April? So this one, again, I don't have all day long, but I'm going to kind of go for the most interesting parts of it. So I'm going to bring your belly up there, the most photographed belly of the day, and if we probably get, maybe, yeah, all right, that's pretty good. So this leg comes out. This is the exercise that's known as the bent knee fallout. Dr. Summer's not big at using that terminology, even though that's her coin. Hip lateral rotation with abduction. So what happens naturally during this exercise? Look at your head, please. Good. So I'm gonna put my fingers on the ASIS and go ahead and bend. Let your leg fall out, and then back up. And again, I hope you guys could appreciate this. Go ahead again. So we have, especially at the end of range of motion, she has a shudder. Now she's got all this great new motion. And I'm not dissing manual therapy. April would have done this right after it. So this is just the way that we're presenting it. She has that rotation every time she moves her hip out. So that means if she's turning one way, it doesn't turn at the hip, it turns at the spine, even though she now has more motion from the manual work. Let's see the other side.
Because remembering too, real quick here, like the motor cortex hasn't changed. The sensory cortex has, but the motor cortex still has the same response, which is, even though we're doing the same test, your brain still hasn't found a new way to do it. So that's why we have to be real specific.
And then in her case, in an extension type syndrome, you're going to have excessive length of the abdominals, you're going to have extensive, more strength, more power of the back extensors. So that's probably why her extension was very strong and her flexion wasn't. Put her back on alignment, allow the motor control to come in now to clean up the mess. So we can appreciate, go ahead, let it out to the side. It just gives way here. But let's do this side. Bend your other leg up because we're kind of focusing more on right side right now, I think. So I'm going to ask you to feel these muscles because she doesn't know anything about these guys other than they're just something on the outside. And it's not the rectus, it's not the six-pack abdominal muscles. It's these big superficial outward rotators, obliques there. So just feel this here and tense that up. Good, get that ready there. Now you also have to be able to breathe while doing it, so it's not holding your breath, just sucking in, bracing. This is stabilizing it. Good, hold that there. Now let this leg come out and go as far as you can before it gives. Hold it, control, good, and then back. Better. A little shaky there at the end. And again, now this is for someone who exercises, you exercise a lot, right? For someone who exercises a lot, this is pretty low end exercise. Go ahead, let's do a few of them. This is very low end, and what we want to do is we want to get it to where it becomes automatic, as April talked about before. One of the ways in MSI is just build it so much that the body's like, oh, that's the motor plan, that's the gross motor program I have. Every time I move my hip, the pelvis is going to stabilize, the pelvis is going to stabilize with the obliques, not with the hip adductors. Go ahead, tighten this up again, tighten it. Come on, get that working, good. You're a champion there, good, and then back. So now the hip rotators and adductors are being used as eccentric controllers of that motion rather than concentric stabilizers of the pelvis. All right, excellent. So we could go on to more challenging ones, which is single leg up, double leg up, leg press. But we're not going to go on that right now. Can I have you bring your head over here so you can face outward? So every failed test becomes an exercise program. If I have 25 failed tests, I'm probably going to pick the easiest one to win so that the patient gets a buy-in to that. Can you slide down a little bit, please? There you go. And then back down. We teach a class on posture, so if I let her stay that way, it's going to be just brutal. So let's look again at this. Any questions while I'm moving through? You guys got it? So let's look at a few things. The good clam or bad clam, let's just see what she's got. Now don't think about all that good stuff we just talked about or the lecture you were in. So I'm going to pinch the lower rib cage, the ASIS, PSIS. I don't want to facilitate motion, even though touching will facilitate something. I just want to assess. So I'm going to ask you to roll your leg outward and then back in. And just, I'm going to keep your feet together. And then go ahead again. So this is pretty easy to see. So there's a lot, every time she rotates her hip, even though she has more rotation at the hip, and someone said, what came first, the chicken or the egg? I don't know. But if you look at, if she has weakness in a muscle, will the joint stiffen up? Or if she has stiffness in the joint, that's not my job. My job is to get them back and get back and going. Now what I'm interested in is, go ahead and tense this guy, and tense, no, hang on a minute. So what she did is the very standard, thank you for doing it the wrong way, she tightened the rectus. And that's going to put tons of compression and lead to more deterioration. So what I'm interested in is, can you tense these guys up together and just stabilize, and not flex, but just draw this up. Now if you see from behind, what we're trying to do is get a nice level spine. Now if I'm not going to have her sleep like this, I'm going to have her exercise like that. So draw this up. Good. Alright, now from this angle, keep that there, because now the pelvis is stable. Bring the knee apart as high as it goes before it starts to move. And then back down. Good. Now you notice a lot less motion. So this is how clams should be done. Draw in the obliques in stabilize the spine, bring the hip into outward rotation, and then back down. And again. Now I'll cheat here, because I'm also a manual therapist. April didn't get to do this, she talked about this. What lives right here that doesn't like when I do this? Right? It's a little tender. So there's the deep lateral rotators are dysfunctional. So this is when I sneak over and do some manual therapy to get in on it, because I want to move it along. I don't want her to be there for a half an hour trying to do one exercise. She'll get frustrated. So I'll do a little bit of manual therapy, come on back. So tighten it up again. Good. And lift up the leg. Good. 5-minute warning. Perfect. Is that what that beeper was? Oh, that's what that is. Good. Perfect. All right. So what am I going to have for home program? Maybe I'll have her do, drawing in the abdominals and standing on one leg. I might have her drawing in the abdominals, lifting the leg up, and sitting. Something easy at home. Definitely a clam type activity. Let's look at 2 more things, and then we'll wrap up and talk about how this all interplays. So hip abduction. Now, again, April just made this a lot cleaner. So let's look at the spine gets protected or relaxed by being up in this position. We get her in position here. Let's see what her abductors look like. So just hold that there. Don't let it drop down. And don't let me push you down. Okay, not terrible. But let's bring your axis. Keep it right where it is. But a lot of tensor fascia, a lot of dominance here. There's a lot of tightness in there. So I'm going to get the back part. Hold there. And it kind of gives, but this is a pretty higher level functioning person. Although she can't do a clam well. But anyway, back to that. Good clams. Good clams. Tighten this up here a little bit. Yes. So what happened, you guys didn't get to appreciate, she still lives in extension. So she's still relatively long here, relatively short here. When I ask her to draw on those muscles, it's not the obliques, or it's not the rectus, it's those obliques. So hold that pelvis stable, tighten that up. Good, tighten it up. Now hold that leg up. Doesn't shudder as much, hold it there. Good. So for home program, for someone who's a little higher level, I might take them off of a wedge or something, foam roll, have them draw on this muscle. Oh, look at that. That's gorgeous. That's like on. That's like, woo. And then she could do small pumps in hip abduction before she moves on to more aggressive technique. Last bit, lay on your belly. This one shouldn't be a big issue because, lift up your leg, you should have good glute hip extension strength. April trained it, immobilized it. Let's see what's going on. So we'll look at see what's going on here versus here. Just lift up that leg there. So see how she outwardly rotates that leg? That's a TFL dominance. This might be more of a motor pattern thing that we want to work on. So this might be something that she has to do in front of a mirror or in front of a loved one that tells her to stop doing it the wrong way. So lift up that leg, and she's very dominant. So outward, push out to the side a little bit, right there. Good, and then down, and lift. So this is to train on the glutes, so those work rather than the extensor. So I backtrack. I thought she was going to be stronger in here. She's actually somewhat dysfunctional. So this might be another little activity that she needs to just build that back up. Yes.
Neither of you addressed the iliopsoas. Is that time, or is that something you don't tend to go work on a
So
lot?
from an MSI point of view, iliopsoas is going to be lengthened by strengthening the hip extensors and glute
Right.
lead. From an IPA functional manual therapy, we go in there and soft tissue treat it, very similar when we do the AP work.
And
So
I would have done it before that.
You would have addressed
yeah,
it.
iliopsoas is one of our big dogs.
Yeah,
So
yeah, I just
we
thought
do
you would-
deep muscle just like April did, and that will help this along. The last little bit, come up on your hands and knees. Just this is Shirley Sarman's key exercise. If I didn't do this lecture without it, so flatten yourself out again. She just likes to cover herself up. Must be that dog tattoo. So we're looking at how does she do with it. So flatten it. Yeah, just go do it normally. So come on out. So she does it. Come on back. So a lot of flexion here. So what we want to do is train her. So keep right there. Flatten that back a little bit. This is another way we get at the psoas from MSI, is doing the heel rocks, keeping the back nice and flat. Just come back as far as you can. Good. You gotta push your capsule stretch your hip. Good, and then back up. She's doing a nice job. You could add in the little obliques, which she's already got going. No, not rectus, but the obliques. Thank you for doing it wrong, so I could point it out. And then come back. Now flatten this out. Flatten this out. Good. Come back. And this helps to normalize a lot of the pelvic rotations that we see with muscle dysfunction and loosen up some of that. So this is an active activity to loosen up passive structures. So for her, home program, good clams, maybe abduction exercise because she's a little higher level, or just oblique firing with leg lifts or straight leg raises. Do a lot of those until that muscle turns on constant and is the go-to muscle. Improve that length, or relative stiffness, so that the excessive length in the anterior abdominals is replaced with appropriate synergy between the front and back and side to side. So big hand for Kat here for being a double patient.
It was hard to pretend to be that messed up.
That's good. Thank you very much for your attention. I don't think anyone's fallen asleep, at least that I saw. It was great.
You get to sign the sign-in sheet twice,